Για περισσότερο από έναν αιώνα βρισκόμαστε στην πρώτη γραμμή της έρευνας, ανακαλύπτοντας φάρμακα, εμβόλια και καινοτόμες λύσεις υγείας που κάνουν τη διαφορά στη ζωή εκατομμυρίων ανθρώπων. Ακούμε τις ανάγκες των ασθενών και λειτουργούμε υπεύθυνα ώστε να διασφαλίζουμε πως οι θεραπείες μας είναι προσβάσιμες σε όσους τις χρειάζονται. Δεσμευόμαστε ότι θα συνεχίσουμε να εργαζόμαστε για ένα υγιέστερο, φωτεινότερο μέλλον για όλους. MSD. Inventing for Life.
The way we see it, the impossible
is not impossible.
The impossible is simply what hasn't been achieved yet.
So we pursue it.
We chase it down.
We tackle it for answers.
We surround it for a way in. This is how every once impossible breakthrough has ever been created.
A revolutionary approach to cancer therapy.
A path to a cure for HIV.
A cure for hepatitis C.
A better, healthier world for every person to live in.
None of this is impossible now because of the people you work with.
The communities we stand with.
And the partners we push forward with.
Together, we've created what's possible through science,
grit,
compassion,
and courage.
And we will do it again.
No matter what.
No matter the stakes.
No matter who says we can't.
When faced with the impossible, we don't falter.
We band together and we prove it wrong.
The impossible
is not impossible.
It's what's next.
C'est notre futur.
우리가 다음에 해야 할 일입니다.
قدم بعدیه.
ano ang susunod.
Es lo que sigue.
呢個就係我哋嘅下一步。
It's what's next.
Tomorrow is a promise, the promise of a new future, of successes earned, as we promise our customers to help them drive healthcare forward. Our customers are inspiring us to reimagine how healthcare should work, where human ingenuity can finally unleash the power of ever-expanding health information, analytics, and technology. Where clinical trials are designed around the patient, where predictive analytics prevent medical errors before they happen, where all healthcare players work together to make patients' lives better, where every medical decision is informed by evidence, where treatment costs reflect the value they bring, where precision medicines seamlessly find their way to the right patient. It's the promise delivered by mobilizing unparalleled data, analytics, technology, and expertise, connecting stakeholders to improve health around the world. The promise rooted firmly in data science and domain expertise, the promise of the future.
At Janssen, we are called to rise each morning and achieve today what last night seemed unimaginable. We are called to blaze paths where others fear to go, to unravel and repair the very code of life, to treat, intercept, prevent, and cure. We are called to open our doors to collaboration and our arms to the needs of each patient, so that what works in our labs also works in their lives. We are called to advance how medicines are made and made accessible around the world. We are Janssen, the pharmaceutical companies of Johnson & Johnson, and we are heeding the call. Bravely and boldly, fighting sickness with science, improving access with ingenuity, and healing hopelessness with heart, until the world's most daunting diseases are found only in the pages of history books. At Janssen, we're creating a future where disease is a thing of the past.
Every crisis provides the opportunity for a breakthrough. In 1849, we made our first breakthrough, an inventive and groundbreaking way to treat parasites. We discovered how to get life-saving supplies to the Union Army. We broke through the barriers of mass production, making penicillin and other antibiotics accessible on a massive scale.
The life-preserving drugs known as antibiotics met the challenges of war.
And contributing to one of the biggest life-saving measures of the 20th century.
We're entering a new era of medicine in which the natural lifespan may be greatly expanded.
We fought polio with an oral vaccine, so millions of children could be children again. We innovated a needle that would be one of the key tools in eradicating smallpox.
The disease has been wiped off the face of the earth.
We took on some of the greatest causes of pain, illness, and early death and fought them with treatments that improved the quality of our hearts, bodies, and even helped the way we love. We harnessed cutting-edge science to create breakthrough therapies that help people with cancer live longer. And now, we have broken through the biggest health crisis of our time. Over 170 years of breakthroughs, and we're just getting started.
You've always been told you have potential. But it's not enough to just have it. You need to feel it. It takes time, sweat, and tears. Some wins. Big wins. It takes a we never settle attitude. It takes work, teamwork, hard work. Repeat, repeat, and repeat. To be shaken, to be awakened, to test your limits. Overcome your fear of failure. It's a step closer to success. Look closely at the possibilities. Keep pushing your mind and body. Whether you're on the tracks, in the labs, or in midair, find your potential. Ignite it.
All over the world, people are waiting for innovative medicines for the treatment of diseases with unmet medical needs. At Astellas, we are united in a common purpose. We will continue to provide innovative pharmaceutical products that address unmet medical needs in order to deliver a better tomorrow for patients.
To contribute toward improving the health of people around the world through the provision of innovative and reliable pharmaceutical products. This is our raison d'être. This is why we exist. To continuously contribute to the needs of society, we must look 10 or more than 20 years in the future and never stop pursuing innovation in everything we do. We'll generate innovation by treating external environmental changes as opportunities to bring value to patients around the world. Our vision is clear. Astellas stands on the forefront of healthcare change, turning innovative science into value for patients. We are changing tomorrow.
The EU is falling behind other regions of the world in getting new treatments to patients, securing R&D investment, and attracting talent. It takes 426 days to approve a new active substance in Europe, compared to 244 days in the US. Expedited pathways exist to accelerate approval of promising treatments, but Europe is not realizing their potential. In 2021, the European Medicines Agency used expedited pathways for just 9% of new active substances. In the US, that figure was 71%. This means slower access to new medicines for European patients. Europe's share of global clinical trials is also in decline. Compared with an average of 25.6% over the last 10 years, Europe accounted for only 19.3% of global clinical trials in 2020. This means that patients in Europe are not able to take part in groundbreaking research being carried out elsewhere. The situation is most acute for the therapies of the future, CAR-T, and advanced therapies medicinal products. Since 2020, CAR-T trials have almost tripled, but only 2 in 10 clinical trials happen in Europe. And during the past decade, Europe consistently hosted the lowest number of ATMP clinical trials compared to the US and China. Aware of the importance of the regulatory framework for its competitiveness, China has hired 1,000 people in 2022 to increase their regulatory workforce. To attract greater research investments and clinical trials in Europe, our regulatory system needs greater capacity, agility, and to be more streamlined. We have put together the regulatory road to innovation, a 12-point action plan to do just this. Don't let Europe fall further behind. Back innovation in the EU pharma legislation.
Για περισσότερο από έναν αιώνα, βρισκόμαστε στην πρώτη γραμμή της έρευνας, ανακαλύπτοντας φάρμακα, εμβόλια και καινοτόμες λύσεις υγείας που κάνουν τη διαφορά στη ζωή εκατομμυρίων ανθρώπων. Ακούμε τις ανάγκες των ασθενών και λειτουργούμε υπεύθυνα ώστε να διασφαλίζουμε πως οι θεραπείες μας είναι προσβάσιμες σε όσους τις χρειάζονται. Δεσμευόμαστε ότι θα συνεχίσουμε να εργαζόμαστε για ένα υγιέστερο, φωτεινότερο μέλλον για όλους. MSD. Inventing for Life.
The way we see it, the impossible
is not impossible.
The impossible is simply what hasn't been achieved yet.
So we pursue it?
We chase it down.
We tackle it for answers.
We surround it for a way in. This is how every once impossible breakthrough has ever been created.
A revolutionary approach to cancer therapy.
A path to a cure for HIV.
A cure for hepatitis C.
A better, healthier world for every person to live in.
None of this is impossible now because of the people you work with.
The communities we stand with.
And the partners we push forward with.
Together, we've created what's possible through science,
Grit.
Compassion.
And courage.
And we will do it again, no matter what.
No matter the stakes.
No matter who says we can't.
when faced with the impossible, we don't falter.
We band together, and we prove it wrong.
The impossible
is not impossible.
It's what's next.
C'est notre futur.
우리가 다음에 해야 할 일입니다.
قدم بعدیه.
ano ang susunod.
Es lo que sigue.
呢個就係我哋嘅下一步。
It's what's next.
Tomorrow is a promise, the promise of a new future, of successes earned, as we promise our customers to help them drive healthcare forward. Our customers are inspiring us to reimagine how healthcare should work, where human ingenuity can finally unleash the power of ever-expanding health information, analytics, and technology. Where clinical trials are designed around the patient, where predictive analytics prevent medical errors before they happen, where all healthcare players work together to make patients' lives better, where every medical decision is informed by evidence, where treatment costs reflect the value they bring, where precision medicines seamlessly find their way to the right patient. It's the promise delivered by mobilizing unparalleled data, analytics, technology, and expertise, connecting stakeholders to improve health around the world. The promise rooted firmly in data science and domain expertise, the promise of the future.
At Janssen, We are called to rise each morning and achieve today what last night seemed unimaginable. We are called to blaze paths where others fear to go, to unravel and repair the very code of life, to treat, intercept, prevent, and cure. We are called to open our doors to collaboration and our arms to the needs of each patient, so that what works in our labs also works in their lives. We are called to advance how medicines are made and made accessible around the world. We are Janssen, the pharmaceutical companies of Johnson & Johnson, and we are heeding the call. Bravely and boldly, fighting sickness with science, improving access with ingenuity, and healing hopelessness with heart, until the world's most daunting diseases are found only in the pages of history books. At Janssen, we're creating a future where disease is a thing of the past.
Every crisis provides the opportunity for a breakthrough. In 1849, we made our first breakthrough, an inventive and groundbreaking way to treat parasites. We discovered how to get life-saving supplies to the Union Army. We broke through the barriers of mass production, making penicillin and other antibiotics accessible on a massive scale.
The life-preserving drugs known as antibiotics met the challenges of war.
And contributing to one of the biggest life-saving measures of the 20th century.
We're entering a new era of medicine in which the natural lifespan may be greatly expanded.
We fought polio with an oral vaccine, so millions of children could be children again. We innovated a needle that would be one of the key tools in eradicating smallpox.
The disease has been wiped off the face of the earth.
We took on some of the greatest causes of pain, illness, and early death and fought them with treatments that improved the quality of our hearts, bodies, and even helped the way we love. We harnessed cutting-edge science to create breakthrough therapies that help people with cancer live longer. And now, we have broken through the biggest health crisis of our time. Over 170 years of breakthroughs, and we're just getting started.
You've always been told you have potential. But it's not enough to just have it. You need to feel it. It takes time, sweat, and tears. Some wins. Big wins. It takes a we never settle attitude. It takes work, teamwork, hard work. Repeat. Repeat. And repeat. To be shaken, to be awakened, to test your limits. Overcome your fear of failure. It's a step closer to success. Look closely at the possibilities. Keep pushing your mind and body. Whether you're on the tracks, in the labs, or in midair, find your potential. Ignite it.
all over the world, people are waiting for innovative medicines for the treatment of diseases with unmet medical needs. At Astellas, we are united in a common purpose. We will continue to provide innovative pharmaceutical products that address unmet medical needs in order to deliver a better tomorrow for patients.
To contribute toward improving the health of people around the world through the provision of innovative and reliable pharmaceutical products. This is our raison d'être. This is why we exist. To continuously contribute to the needs of society, we must look 10 or more than 20 years in the future and never stop pursuing innovation in everything we do. We'll generate innovation by treating external environmental changes as opportunities to bring value to patients around the world. Our vision is clear. Astellas stands on the forefront of healthcare change, turning innovative science into value for patients. We are changing tomorrow.
The EU is falling behind other regions of the world in getting new treatments to patients, securing R&D investment, and attracting talent. It takes 426 days to approve a new active substance in Europe, compared to 244 days in the US. Expedited pathways exist to accelerate approval of promising treatments, but Europe is not realizing their potential. In 2021, the European Medicines Agency used expedited pathways for just 9% of new active substances. In the US, that figure was 71%. This means slower access to new medicines for European patients. Europe's share of global clinical trials is also in decline. Compared with an average of 25.6% over the last 10 years, Europe accounted for only 19.3% of global clinical trials in 2020. This means that patients in Europe are not able to take part in groundbreaking research being carried out elsewhere. The situation is most acute for the therapies of the future, CAR-T and advanced therapies medicinal products. Since 2020, CAR-T trials have almost tripled, but only 2 in 10 clinical trials happen in Europe. And during the past decade, Europe consistently hosted the lowest number of ATMP clinical trials compared to the US and China. Aware of the importance of the regulatory framework for its competitiveness, China has hired 1,000 people in 2022 to increase their regulatory workforce. To attract greater research investments and clinical trials in Europe, our regulatory system needs greater capacity, agility, and to be more streamlined. We have put together the Regulatory Road to Innovation, a 12-point action plan to do just this. Don't let Europe fall further behind. Back innovation in the EU pharma legislation.
Κυρίες και κύριοι, καλή σας μέρα. Σας παρακαλώ, πάρτε τις θέσεις σας ώστε να ξεκινήσουμε. Θα ήθελα να καλέσω στο βήμα τον πρόεδρο της Ethos, τον κύριο Κωνσταντίνο Ουζούνη, για να κάνει το δικό του καλωσόρισμα.
The CEO of Ethos Group.
Κυρίες και κύριοι, καλημέρα. Ευχαριστώ πάρα πολύ, Εμίλια. Για άλλη μια χρονιά είμαστε κοντά για να
together to discuss about health in Pharma Health Conference, a conference of the most important one organized by our company among the 20 we organize annually. And in this framework, we are at a timely period. There is a new situation in our country, a government that wants to move forward with reforms, changes, and programs that will be to the benefit of our country. And health is a priority to the government according to declarations of the Prime Minister. Of course, health includes pharma industries as well. So it is important that today we have among us two ministers responsible for medicines, and we have with us representatives from pharma industry. We thank you all for supporting this conference, and I would like to thank all the sponsors, Exclusive Gold, Silver, and all those companies that have assisted us with their support. And we have the support of all the associations of pharma industries, medicines, etc. That means that with all these forces and our communications forces, it is sure that under the guidance of Emilius, today we will have an extensive discussion about all these issues touching upon our sector. The aim of this conference is to initiate a networking, a lobbying area where all voices will be heard. We promise that not only during the conference but through our media we will disseminate all these things that will be discussed here. It's important that ever since the beginning of the pandemic with digital business communication we cover this event. And our sponsors have their own digital kiosks. And for you who wouldn't attend it all day, you can attend the conference via live streaming. And you can interact with the rest of participants. I don't want to take more of your time. It's going to be an extensive, long conference. We are supporting this sector. We wish you all the best with the conference, and we look forward to your outcomes. Good morning, everyone. Officially, the 14th Pharma and Health Conference. Health on the spot.
For the first time, after 25 years, we see that there is a political will to change the national health system, and we have a new government invited to make changes. This is the focal point of this conference, to help the government understand what the problems are in order to solve them. We need to promote accountability on every part. Everything might sound easy when we talk about all these things, but there are some interests that are protected. Solutions are not easy. By hiring more doctors or nurses, problems are not solved. In order to change the NHS, all of us need to cooperate. As head of this conference, I invite you to actively participate. And let's be bold. Let's stop being hypocrites and speak the truth. I would invite the first speaker, Mr. Pantelis Mesaropoulos, MD, MSc, PhD, President of Ketekni. I would like to thank Mr. Negis for the invitation to this conference. This conference is a reference point to present new things, and I'm glad that this year we have new things and innovations to present with regarding the Center for the Cost of Hospital Services. The title of this conference, Changes in Health and Health on the Spot, and that concerns the DRG system. The DRG system, as you are well aware, was introduced later than in other states. I don't get into details about DRG. I think more of you are aware of that. So I will just tell you that it is in a way responsible for a fair allocation of money and measuring the work offered by hospital. Why DRG in the center of interest? A fair allocation of resources. Hospitals at some point need to be financed because through their work produced. We need to see the quality of this work to promote transparency in order for a hospital to get more money, to have a system that will be planning and rational decision-making with regard to the personnel, to the equipment, and the support of NSRF and decision-making with regard to our hospitals in the center and the regions. Let's not be fooled. Every change in health has two objectives. The patients, above all, to get better services. That is one of the most important objective for the ministry and the doctors. And the second objective, the second part, is those involved in health to have better working conditions. All these, of course, need money. And for the hospitals to be able to program things, and the ministry to be able to program things, pricing and remuneration of hospitals need be quite fast, and we need to have a simple but effective system. And in order to have all this, the ideal is to be part of the new era. And new era with paperwork is not the case. So we need to abolish the traditional ways and have a digital archive. So digital transformation is the big bet, and we have won that, I believe. When we tried to implement that, and there was an issue about codifications, etc., in a discussion with Yannis Kotsopoulos, who is here with us, the question was raised on how to introduce this data, and an e-file, patient's file, can solve the problem. We chose that, and we have two health region part of the system with an e-patient files. All the data we get all the data from the source, and we expect the ministerial decision. So all hospitals are part of DRG. The first hospital, pilot one, not because it was in a pilot application, but it was the one we wanted to show to the rest of the hospitals. We paved the way. We tried to have a role model hospital with regard to procedures, and the aim was the other hospitals to follow. I have explained the reasons why we have chosen this hospital. They were aware of DRG, the administration was very favorable, and the conditions were also there. We wanted later to include the rest of Crete. The programming for then was only 3 hospitals to be introduced, but we included the whole region. So we had a motto: do it as Cretans do it, and we won this bet, and we are here now to include all hospitals of the country. The hospitals are ready. A joint ministerial decision is expected in order to achieve this goal. Not an easy task, though, but the objectives are there to cover everything and win.
So we'd expect that this would become a reality in due time. Kevni set the foundations for what we wanted to happen. To begin with, this was an introduction to a new system in a digital way. This means that we should convince EOP to abolish the natural file. The archives were in paper. And then, of course, we had the choice for reviews. But now the submission of any document is done via digital way. The hospitals now need to codify all the stays, and as regards remunerations and fees, this will start for the regions in Attica after the ministerial decision. Until then, we provide a fee of as the average of the 2 previous years. So the system is not going to create any monies. The DRGs are not going to solve the problem of lack of funds. But it is a just system, a more efficient system than anyone that we had before. Of course, in order to reach the completion of this system, we needed the cost weight parameters. So we had to set the unit price, which is important for our budgeting. This is very important so that we can see how the monies will be spent and used. So this means a healthy competition in between health regions and hospitals. After the analysis that we have run, we can multiply the unit prices with the cost weights, and then we can reach the amount for every DRG. In countries like Estonia, they have a national-based aid without any differentiation in between the hospitals. They have a flat rate. Also, we have this in other countries, for example, Germany, per state, and France and Portugal as well. For now, we can take stock of the cases in every hospital and see which are the more complex ones in order to see what model we can create. We have real-time data now, and we can analyze all the data set that enters in our systems. We can see the various clinics, we can see the cases that the clinics have. Of course, intensive care units have an increased rates, not as expected for an intensive care. And you see which are the differences in between the clinics. As I said, the formula to compute the fees for every hospital is related to the cost weight equation, the base price, and an extra factor, an extra parameter, because the funds come from a specific organization nowadays. So AOP needs to know beforehand how much they should pay after the salaries cost. This has to be introduced into the final DRG. Of course, this could not happen quickly. So we just leave it there and we create a different DRG with different variables. So we based our work on 4 main pillars. The first was codification on a mass basis. The second was user training. It's a very important dimension. Also, remunerations is the third pillar. We are expecting the ministerial decision. And then we have the other pillar, which is quality. All data have to be filtered in terms of quality, otherwise we cannot be sure that we have good quality data. If we do not control the data, then we are going to fail. So, Ketechni, after the massive codification of all cases, has entered a quality control system. So data quality is a very important prerequisite for a good DRG. So always we need to train continuously all the users of the system so as to have good data. Trainings are delivered by Ketechni. We have trained more than 6,000 health professionals or retrained them. We also have an e-learning platform. And of course, we have the excellency code so that we can know how the advantages are going to be addressed to all the hospitals accordingly. As regards data quality, I am happy to say that at the end of this month, we will have a special control platform, review platform. Until the end of 2023, we are going to check all the cases of the 7th region, one after one. And after this pilot, we're going to use the real-time data to control them so as to increase quality and provide further and better trainings. Platform Hospital Future is our motto, and I believe that, as you have understood, that this is our future. These are the real data that we take real time from the hospitals. Data analysis with monthly reports. I had a meeting with Mr. Themistokleous, the minister, last week, so that we can analyze the data. This is the mix that we get. And that's the timeline so that we can reach in March 2024 in the position to cover all the hospitals. We had a short delay due to the elections, but we are ready to deliver. Thank you very much. Thank you, Mr. Mesaropoulos. This was a very good presentation. After that, after the keynotes, we'll have a panel and we'll see with Q&A what are the details of this system. Let me now give the floor to Mr. Karokis and Mr. Apostolou. Mr. Apostolou is going to speak about centralization of procurements. Good morning, and I would like to thank the organizers for this invitation and the opportunity that they give me to present the progress in EKP in relation to centralization of procurements. It's important to see where we start. Marios Themistokleous told me that when he started, he only had 7 personnel. This was the mentality of centralization after the memoranda era. This legacy of 7 people would manage the billions of the funds for health. They didn't have even a contract for cleaning the building. They had the key and they would enter by themselves. Then we had the COVID pandemic, so we had to see how to deal with the situation. After him, after Mr. Themistokleous, we had Mr. Bartzokas. And he was more active with EKP. So the legal framework was changed then, so that this body become more flexible in order to implement the central policies, the national policies. They also wrote technical specifications. Last year, in the 13th Pharma conference, we spoke about the programming of this project. For 2023, we created a strategic plan of various projects for the procurements for all hospitals. At the same time, for our better operation, we invited a call for 40 special scientists to be recruited in September up to October, and they would work on an operational basis. After that, we have carried out the following tenders: medical cotton,
είναι τα αναλώσιμα υλικά για την αντιμετώπιση του ισκαιμικού αγκιακού εγκεφαλικού επεισοδίου, 65 εκατομμύρια ο διαγωνισμός, προμήθεια ψυκτικών θαλάμων που ήταν απαραίτητη για τη συντήρηση των εμβολίων κατά του COVID, υπηρεσίες διαχείρισης των αποβλήτων των νοσοκομείων με 109 εκατομμύρια, προκηρύξαμε ένα διαγωνισμό φαρμάκου με 5 δραστικές ουσίες και συνολικό προϋπολογισμό 60 εκατομμύρια. Αυτό έχει ολοκληρωθεί.
The auction has now finished, and we are going to award the tender within 7 months. In other words, the tenders have now a shorter time period. We have invited tenders for various materials that we need or services for our units, for ischemic cases. This specific tender will also include an IT system plus a service to support the procedure. Also, we have a tender for vaccines warehouses. 300 million in total. Under the RRF, we undertook a media campaign, which is the first RRF project that has already been paid. Also, we had the horizontal technical assistance for the Ministry of Health. The reform at first degree which is the equipment for the health centers. We already called a tender for this project. 81 million for equipment for hospitals. We are at the stage of evaluating offers for centralized procurements, and as regards Sotiria Hospital, until the end of this year, we have various tenders in queue for various equipments that we need for different types of hospitals. Orthopedic cases, cardiac cases, also reactors for the laboratories. In the conference that was held last year, I had already announced the centralization of the codes that we use so that all hospitals plus the administration are using the same language, and this project is already implemented, and I'm very happy that I just heard Mr. Messaropoulos presenting it. Today we are announcing a tender for the consultant who will undertake codification for all materials used in all hospitals. At the same time, we have an electronic system for consumptions on the EKAPI.net platform via open channels with the hospitals. We are going to exchange information. Instead of exchanging Excel files, we are going to be mining the data from the hospitals directly. At the same time, we proceeded to centralize the ordering and procurement of drugs. We have already implemented the platform, and is now used for more than 750 users. Actually, in all hospitals, pharmaceutical companies. This is a major reform in our opinion. We have central information to manage drugs. We have digitization of the process. We now know which are the needs. We know this in a timely manner, and we have the opportunity to plan new tenders. We see how the contracts proceed, and we know whether we need something more. The first group of drugs in this platform were the tenders of 2019. Now we are running the contracts of 21 and 22. In stage B, we are going to introduce all the negotiation findings. This is going to start implementation on October 2. This was a decision taken yesterday. This is a major reform, especially as regards the negotiations committee. Timely and direct operation of such discounts is very helpful for the overall financial systems. The platform is in place. It creates automatically the ordering slip that has to be signed by the pharmacy. Already we have carried out 514 orders. We have executed all of them. and we will settle May very soon, and we will pay the pharmaceutical companies right away. Thank you very much.
Ευχαριστώ τον κύριο Αποστόλου. Κατά πρώτο...
Thank you, Mr. Apostolou. We will have, of course, the opportunity to discuss everything during the round table. Mr. Mesaropoulos also and Mr. Apostolou both have proven that something is happening in this country. I would like to invite Mr. Karokis, CEO of MSD Greece, who will talk to us about the need to change the pharmaceutical system in Greece. Thank you. Good morning. Thank you very much for the invitation, and we will talk about how we could change the healthcare system financing. We need to see how it works for everyone, for all those involved. I will give you certain examples that concern the healthcare financing in general. There are some common problematic points in various parts of healthcare financing. I will start by saying that every year the state, the hospitals and patients suffer more compared to previous year. This system of financing as it operates is not the best available and is to the detriment of everyone. This system has a projection of financing by 2026, and I have stopped in 2026 because RRF will stop financing health by then. We see what the state pays, and I have included RRF in that, even though not all of the funds of RRF go there. The orange part represents the part of the industry, rebates and everything, and the green concern participation of patients. What we see, unfortunately, is that in 2023, spending will be at the year 2009 levels, 7 billion in 2023, and in 2026 we will have reached 9 billion. The participation of patients which reach 1.6 in 2026, despite the declarations of the government that it will decrease the expenditure of patients in the near future. What we see is that in 2026, since we will have no money from RRF, and we will see without RRF, after 2026, for every euro spent in health, 30 cents will be contributed by the state and 57 euros by the industry. So we need to see how we can revise all this in order to have a balanced contribution of all interested parties. We need to increase the participation of the state to the benefit of all of us in hospitals, for example, and AOP. The pharma industry, if the situation continues like that, should contribute with 69%. But you understand that pharma industry has other interests as well. We spend money in research and other tasks. So if we continue contributing in the healthcare system with this amount of money, unfortunately, we won't be able to support innovation for the pharma industry in Greece. We also see that we have segmented budgets. This creates weaknesses in managing healthcare. And we see that with the expiry of patents, nobody has won. Every part of the expenditure, healthcare expenditure, is cost unit. We have lost the mechanism of redistribution, internal redistribution of costs. The third part is that we have differences among different channels, which is to the detriment of us. And we have differences among patients. For example, an oncology patient won't get medicines from pharmacies, but from specific points. So we have inequalities among illnesses. And if somebody wants to have access to innovation, should spend more money. And in order to do that, we need to save money from other categories. It is like our child enters university and we don't want to change our budget, even though our child does not live in our house any longer. That increase, so we need to revise things. There are other factors as well that favor high expenditure. The financing mechanism rewards increase and not decrease of medication. We have in a DICA database nobody takes care of for many years now. We are insisting on that We need to analyze all the data we have in order to take more rational decisions, because with that we can be able to allocate money better. We have lack of control mechanism with regard to expenditure. Our company has given more than 120 million of rebates this year. If we stopped that, we would have been able to support the whole system in a rationalization of it. And the system could have saved 30 million euros. We need all of us to sit around the same table and discuss the same language. Otherwise, we won't be able to find solutions to the benefit of all of us.
Είναι ένας βασικός παράγοντας που οδηγεί στην κακή διαχείριση.
With the discounts, we cannot solve anything. The state, of course, has the right to say that I can choose this medicine compared to that, or choose certain companies. We are not in the era of memoranda. We are in a flourishing economy. The system cannot flourish by thinking that some will pay more than others. So in general, the system should change. We have we see here the contribution of various companies in expenditure. So the companies are not paying according to what they say, but according to the budget and their market share. What has remained? So companies should evolve, because if they stay stable, they lose money. So the companies usually make haste to sell more. That is the problem of the system. In order for the companies to earn more is to sell more. But this no company can operate in an environment where companies sell less. That is why all of them try to sell more in order to survive, and that is why expenditure inflates. And we must never forget inflation. Inflation operates to the detriment of all and the companies. So I say that this system should change, and this is not a problem of the industry but of the state.
Δεύτερον, οι συμμετοχές των ασθενών αυξάνονται, και δεν μπορώ να καταλάβω τον λόγο. Τρίτον, η κυβέρνηση αναγκάζεται ήδη να βάζει χρήματα στο σύστημα υγείας και θα βάζει τα χρήματα χωρίς μέτρα ελέγχου του κόστους, άρα τα
So in any case, we need to have to find a way to solve these issues because the industry should continue its research and provide better quality of products, but that cannot happen unless we have funds to invest in innovation. We need to, in order to solve all these things, to find, to see things in their dimensions. We want to understand what is the real expenditure we want and to the benefit of whom. We need to revise the rebates mechanism, and we need to balance with what we spend and what we earn. What has happened in the country is that the LP at some point decided not to be interested in what it gets, but to what it spends. But on the other hand, it wants, as an organization, to protect the health of the patients, but without taking into consideration that some of the medicines have increased prices. We need, in other words, to revise this policy. We need to create a mixture of policies to quantify it, measure it, and we need to have a mechanism of control. All citizens need to know where the money of the state is spent, and all categories of healthcare need the same attention. We need to use data in order to take decisions, and we need to think that the state should take some of the burden of medicines in order to protect the patient's health. But that can also be done by taking into consideration the changes that occur. You cannot transfer the cost of a medicine to others. We need to give respect to all those involved in medicines. In hospitals, for example, there are some special medicines that are not so commonly used, that these medicines should be taken into consideration and see how they can be managed more properly without affecting the general cost. We need digitization. Of course, I won't say anything on that because there is an effort on the part of the state for this digitization, and of course we need to have algorithms, etc., and the rest in order to have a more rational management of everything. We need to have a specific strategy with the budget to take into consideration all contingencies. I say that because if at the end of the day we manage all this, we will have a better health care for the patients and a more fair allocation of funds to the benefit of all. This is a triple win for the patients, the state, and the pharma industries. We need a multidimensional strategy in order to achieve all these. Thank you very much.
Να ευχαριστήσω τον κύριο Καρό και νομίζω ότι ο χρόνος που πήρε από την παρουσίασή του λίγο...
Oh, okay, we'd like to thank Mr. Karokis, even though he has exceeded his time, but he had a very interesting presentation. I would like to invite Mr. Vangelis Hadjigeorgiou, CEO of Impact. He will talk to us about digital transformation and the future of electronics invoicing, unleashing efficiency and innovation.
Καλημέρα και από μένα. Σας ευχαριστώ που είσαστε εδώ σήμερα.
Welcome, everyone. I'm going to try to be brief and give you a glimpse of the technology that we are using. We're going to see how electronic invoicing can promote digitalization of the enterprises, so all business units can be more efficient and have the characteristics that are perfect for business. Let me start with a couple of things about us. We are in the technology market for more than 20 years. We have done very complex projects in invoicing. At the same time, we try to cover all the needs of our service, of our business, in automation of invoicing and supply chain, aiming at digital transformation. We were one of the first companies to provide invoicing services for our customers and for multinational companies. We are members of the European Invoicing Association, dealing with paperless and digital processes. Which is very important for B2G issues in the public sector. 1 year ago, we entered SoftOne, which is one of the major suppliers of software, IT solutions. We operate in this market for many years, and we created the merge of Impact and SoftOne with 80% of electronic invoices in Greece. We are leading the market, and we create more than 45 million. So e-invoicing is here to stay. In this graph, in this map, you see e-invoicing in various countries. We have the main block of countries. Greece is in the second part of invoicing. There is a trend which is increasing. Also, we have other countries that are now starting. So let me explain what e-invoicing is. It's the service allowing an organization sending bills without printing them or archiving them. This takes place via this other platform. We don't care which system you use. We can plug on every system, every platform. You can send your invoices to the end user and to the my data of them. Management is also automatic. Advantages. Electronic invoices automates the whole process. Also, you have your invoices on the cloud, archived, safe. As the previous speaker said, paperless is an important step for the user experience, and also it decreases the time for processing. Advantages are decreased DPO, collection is difficult in industry. We can help with faster collections. We can have agreements with the accounting offices. Our model is based on transactions, so the cost is very low, and we have a fast ROI on your investment. Something that you might know is that starting from last April, a ministerial decision was voted for compulsory invoicing in the public sector. Impact was there. We supported this change, and we've been trying to help the state automate the billing process. So this is an advantage for all organizations because they can have control over their invoices and the step of payment, the progress of payment. So we have a new relation in between the state and the businesses because the whole process is more transparent. This is very simple, a simple process for us. As I mentioned before, we can plug onto any platform you're using, so we can connect onto any system. What is important for you is that you don't change the way you function today. Our service via the PEPL network, dealing with the public sector, can send the invoices to the end users. This way, you'll be able to follow all steps of invoicing. ESG is important. It is high in the agenda. As an organization, this is something that we want. We want to help the businesses to proceed into these procedures. We also have a lower environmental impact, a footprint. So we are ecological. Also, we adopt practices that promote corporate responsibility. Now, as regards the next steps, as I said before, after this ministerial decision, it is compulsory that you go for e-invoicing. The government wishes to reach complete electronic invoice for B2B and B2C levels. As an organization, we provide further services. Apart from the invoices, we can also support e-payments in cooperation with banking institutions. The next steps, these are the next steps in combination with banking institutions. I would like to thank you for your attention. If you need any further information, I'm here to speak with you. I hope that we'll have a very good conference. We are here for anything you need. Thank you.
Και εγώ ως ελεύθερος επαγγελματίας έχω...
I have started from the beginning of this year, after the extensions that we got. We have now the compulsory situation. Now, I would like to ask the panelists, Mr. Kotsiopoulos, Secretary General of the Ministry of Health, Mrs. Apostolou from the Central Procurement Organization, Mrs. Kaitailidou, Professor of Public Health, Mrs. Karpodini of EOP, Mrs. Kostoulas, Commercial Director Impact, Mr. Mesaropoulos of the Get and Key, Mr. Rolandezos of the Pharmaceuticals Association, and Mrs. Zanlakis of Government Affairs, Gilead Sciences.
Ωραία.
The number of participants shows that these discussions are very interesting for all. I would like to start with Mr. Kontsiopoulos. We're going to have several questions for them. I believe that this question is reflecting the thought of many participants. So what are you doing? Are you staying? Are you leaving? What's your plan? I guess that most are interested in reforms in the health system. So we'll see what the decision will be. Recently, you spoke about the 6 basic axes for the country so that it can change their health system. Which are the main pillars that should be set as a priority? We have already started with the reforms. As we heard in the previous presentations, we see that we have started already changing things. In the last 3 years, we had to deal with the pandemic, which was a very important project. ECAP had a very old and obsolete legal framework, so we had to start from the beginning. After the end of the pandemic, we have accelerated the pace of reforms. Of course, we need to see the structural changes. Reforms have delayed in certain areas, so we need to accelerate this. Of course, systems change because the needs of patients change and technologies change as well. So we need to consider all situations. Certainly, we need to see integration as a priority. We want to revisit the structure of the national health system. We have analyzed the patient's needs. We need to see exactly which are the needs of the patient and then understand which would be the major solutions. For example, home therapies. Home therapies, is it a good or a bad thing? Is it better for someone to stay at the hospital for months, or should they go back home and continue their treatment there? We can provide several solutions in order to give new models of health, of care, which are tailor-made based on the patient's needs. What about the measurable objectives in this new project, in this new program? We know that we want to decrease the waiting time, but I see that there might be some difficulties here. Already we have started speaking about the challenges of waiting times. This is related to the reform of the health system. We have to forget the procedures of the past. We managed to provide less waiting time for those who are in the waiting list. This is to the benefit of everyone. You know very well that the Alekos Papadopoulos was the minister that changed the map of health in Greece. But we need to do more. So what about the backstage, the back offices? From the visits that you do in the hospitals, which are the more urgent challenges that you need to face? Thank you, Mr. Negui. Speaking about the under-the-radar processes, the back offices, because very quickly we had to create a policy for quality assurance. The European Union imposed comparable measurements after 2021. When ODP started, they didn't have not even one person in its staff. We created several indicators and we saw that things are where we want. We took stock of what goes on and we saw which are the challenges, the main challenges that we have to deal with. Unfortunately, there are no procedures inside the hospitals. We need to differentiate the large and the smaller hospitals. So we want to develop certain procedures in order to understand which are the main solutions. We spoke about changes and we spoke about funds. Sometimes the solutions are easy. We now have mechanisms, we have the data, so we know where we stand. For example, we know that falls of the patients while in the hospital, for example, is 4% of the expenses in the British hospitals. Now we want to see whether this can be utilized this knowledge can be utilized to our benefit. Of course, there is a series of issues. As Mr. Konstiopoulos said, we have scanned at least 15 hospitals, and now, for the first time, we are introducing indicators. The various hospitals have different systems, so we want to see what kind of indicators are used in other countries in order to follow the journey of the patient in the hospital. And what about data entry? How is this going to be materialized? Will people enter data? We developed 40 basic indicators demanding minimum human interaction so that we do not burden the organization with the personnel costs. This is a quality indicator. Will ODP also train users? It is in our statutes. But as Mr. Mesaropoulos mentioned, we start setting this as a priority. We have started with trainings for quality processes for all ranks of personnel. As you understand, there is a quantity issue. It is very important for us to support skills. The fact that we have delays in digitization in the national health system make us understand that we miss some data. We need to speak about clinical findings, clinical data. So, do we have uniform services in the health system? Or do we have differentiations that we need to measure? Before I give the floor to Mrs. Carpodini, I would like to ask from everyone to speak also about the training of journalists, about what you do. We heard a lot, Mrs. Carpodini, but we didn't hear anything about AOP. Which are the basic challenges, in your opinion? To begin with, let me thank for this invitation. This panel is indeed very interesting. As the Minister has said, this whole effort can succeed if we act together. We need to coordinate our efforts in order to be successful. Also, we want the monies that they have promised us. We need to have the budget that we were promised. So I hope that we will have these monies in order to work. So it is a priority of you to make this organization independent. Indeed. And I'm not speaking only about money, but about administration. AOP has a very central role to play in this reform. The role of AOP is central, as we all understand, because we are utilizing the state money for the end users, which are the citizens. We have to manage our funds in the best way in order to ensure the best access to the best therapy for everyone. So the organization should prioritize the solution to these challenges. What about the transformation of AOP? Already AOP has taken several measures, taken steps, so that it becomes a modern, flexible, and transparent organization via the RRF for operability and interoperability of all systems. We will manage to do this since we have already proven that we can implement quality criteria to give to our insurees high quality services. Recently, we introduced quality criteria in MRIs and scanners, and already we have managed to have modernized 30% of our infrastructures. This means that that all the services are uniform, are very well cross-checked, and are high quality for every end user. In other words, it is important to consider that we want to provide same quality for all end users, for all users. We need to have the same measures and the same criteria for all. Health is a public commodity. Very well controlled by the state. With real-time checks so that the patient's journey in the hospital will be as smooth as possible. No matter whether they want to come for diagnostics or for a surgery or whatever. So real-time checks are important. This means that we have to introduce quality services. It seems that the DRGs seem to be successful until the end of this year. So, what is the situation for AOP? At the moment, the fees to hospitals have increased. 60% is given by the ministry and 35% is given by AOP. As Ms. Scarpodini said, this was a high priority for the state, and that's why we managed to prioritize payments to the hospitals. So now compensations are managed mainly by AOP by 80%, and this will be done in a more just system for all end users. We will know which is going to be the salary cost, and it will be paid from the same source. We have the technology, we have the process, and we need to be able to see the great picture. So we need to have the proper data, a good invoicing model, so that AOP can compensate after carrying out the high quality checks. Payrolls, of course, have to enter into this equation. As, for example, in the pandemic, we created mechanisms in order to cover all situations.
Nonetheless, we need to see that all this expenditure and know where we need to take each service. If we don't add quality and effectiveness, we won't be able to choose properly. We need to know exactly what is happening. So we're not. I'm not just cutting somebody out because I want them to take less, but because their services are not the proper one. That we should do that in the public sector. In order for the public sector to do that, is to operate in more rational approaches. AOP compensates certain hospitalizations, but what is happening is to do it beforehand. We need to have a programming from the beginning via contracts and be able to say that I buy operations 700 from the state and 300 from the private sector. These operations, surgeries, should be paid beforehand in order to program patients better. We did that during the pandemic where we programmed purchasing certain services from the public sector. Having talked to many representatives of the state, we see that they have opted to buy certain services from the private sector when they are not offered in the public one. So if we have somebody else who just decides to make a private X-ray clinic, so they have contracts with AOPs. Yes, we need to service the needs of the patients per category. We need to have contracts with providers, but we need to have quality criteria in order to offer these quality services. We don't need to have an ad hoc system. This is our main problem. We are an organization which passively signs contracts with everybody. We buy from everyone, and we don't have the ability, as Mrs. Kosiopoulos said, to go specifically to contract certain needs. You talked about waiting times in TEPS. We don't have a previous degree that will prevent from the emergencies of hospitals, something that can be dealt with in primary health care. We need to see this map. What we have in public sector, where what do we lack, and have contracts. Okay, I need a healthcare center in Rafina. Does it is it standby? Yes, it is. What does it lack? It lacks this kind of service. Okay, so let's purchase it from somewhere else in order for that in order to offer a full service. We have heard a lot about health, etc. What are your expectations from the government with regard to medicines? Thank you for the invitation. Well, people who pay are the last to talk. We will pay rebates more than 2.3 million. Well, financing is the most important thing. We have seen everything. There is an inequality between the needs. We're talking about programming of actions of the next period, where this very moment we miss data and we cannot program. But I remind you that we are in July 2023, and now we got the clawback of the from the hospitals for 2022. There is a big issue. We are in discussion with the state in order to find some solutions in order to abide by the law and things move forward. So for me, financing is quite important. Financing is important because, and in order to solve the pending issues, we need to find some cost centers. We need to support the expenditure of premiums. Also we need to talk about the expenditures of citizens without social security. Who is paying for them? We are paying for them. I think that the state has already taken steps forward. For example, during the pandemic, the state has purchased the vaccine. We have carried out a study, but we have fresh expenditure, which accumulatively in 2023 was 826 million euros. So you can imagine. Our suggestion is to have a more rational financing in order to cover for the state to cover the expenditure of people without social security, and and a way to tame the galloping expenditure. But we see that expenditures rise. 350 million of people without social security, if covered by the state, still there are money missing. Well, yes, but we need to take steps. Digitization will solve part of the problem. We need to develop a mechanism to have data interoperability. We haven't achieved anything from that. We miss operability. All this is excellent, but we have had 2 difficult years. What we do now does not operate right away. It will start operating after a while. So we need to, for example, introduce filters in prescriptions, which is quite important to all. There are some things that need to be done right now, directly. That could happen. Unfortunately, they don't happen. Do you believe that ministers who take decisions are thinking of being judged for putting limitations? No, because we have tools. We need to properly use them. Yes, I will agree. Totally agree with you. We understand how difficult it is to take difficult decisions, but it is also difficult for the industry to survive in such a negative environment. Mr. Giannakis, in public discussion, there is an idea to alleviate the costs from pensioners, and they suggest to decrease their contribution to medicines. Well, it will turn back to you. Mr. Giannakis, you are at the other side of the table, but we have common problems and points of view. In medicines, in hospitals, we have serious problems. What can be done? What suggestions you can bring in order to improve things in hospitals above all? My colleagues said we expect the note of the first semester of 2022. The final account, nonetheless, will be given by the end of the year, and with a question mark. I believe that the part of hospitals, beyond some things that are not predictable, is quite controlled. A feeling from the first figures we have is that the account for 2022, the whole burden will be to 80%. So you see that this is not sustainable. Question marks, I said, but the total expenditure of 2021 closed in the first quarter of 2023 with an addition of heparin. So if we lack this kind of knowledge before going to transparency, we cannot take steps. As it has been said, we need to take advantage of the data. We need to analyze the data. At a second degree, I will agree with Mr. Olandesos. We need a control mechanism. The prescription filters should have been already introduced. We have a deficit. The state should look into it with the abolish of controls in EOP. You can have controls, if I'm not mistaken, but you cannot impose penalties if there is a wrong prescription. In medicine, there is different legislation. We have a control directorate. When we have additional prescriptions, when we have other problems. We send some notes to the doctors telling them that they have exceeded their prescriptions of certain medicines, and be cautious. Something else which is very important for the reform you have asked me, and the transformation of the organization is to understand that all of us, all organizations involved, in order to be able to do our job properly, we need to have access to the insurance data of the patient. We can have digital files. The data are there, but we don't have access. Do you believe that we have a discussion for a medicine of a chronic disease and we don't have a list of patients in order to know how to make the negotiation because we don't have access to them? Well, we need to eradicate all these problems because, as Mr. Olandesos has said, we need to have different stages from the least effective to the most effective. This is quite important to know how to do that. Well, we were very happy for e-prescriptions. We need to, that is a first step. Well, e-prescription doesn't mean I don't go to the doctor. We did that for the pandemic as before. We did that before the pandemic, but we did that as AOP for those suffering from chronic diseases. We didn't do that for everyone. We did that for those who have chronic diseases and need be protected. E-prescription was there because we didn't want to carry with me papers. Not to visit the doctor. The doctor will judge whether he will see me or not, because if doctor sees that I don't need to be examined further for the prescription, the doctor says, okay, I can prescribe a test, and then you, following the results, come here and see if we will continue. E-prescription does not mean telemedicine. Mr. Apostolou, I saw an interest from central procurements. When will this system of central procurements will be initiated? It has started since May. In what categories of medicines? In those agreed by CAPI. We had a competition. We had the contracts for the providers, and now we have the contract signed with the pharmaceutical industry. This part already operates. The one which was extended has to do with medicines that have derived from the negotiations committee about the discounts with closed budgets, etc. That is the part which is still pending. For the 7 months was 44 million. We have the credits, and we manage that in the market. That has nothing to do with the negotiations committee. The negotiations committee had done what it should it should have done. It talked about credits, 175 million. When you try to implement it in the mid of the year, from the credits you have already awarded to get it back and give it someplace else. So we need to adjust all the budgets of all public entities. This procedure is very complex. EKIPA had to do that. Did you decide to do it? No, I think that it was a central decision, wasn't that? What Mr. Apostolou says is that the combination of these systems or the introduction of this system should be done at the beginning of this year. We need to program everything beforehand, because the main burden for the hospitals actually is seen during the second quarter of the second semester. But people that participate in this field, they had to face measures that were taken retrospectively. That is a huge problem. When we talk about some regulations, they were introduced retrospectively, and those people who participate here already inform mother companies, etc., etc. So the commitment here is that we will have everything now operating properly since the 1st of January 2024. Yes, we will try our best. We are working towards this direction nonetheless. Is it feasible to implement? So when we talk about the budgets of hospitals, is to assure proper operations of hospitals. Above all, we will work hard to see if in October 1st we can take the steps necessary for the hospitals to operate properly and then protect the state as well. Mr. Kostoulas, a lot of transactions are not carried out electronically. Public administration has done has taken a lot of steps forward towards digitization. Evidently, there are a lot of issues that can be that can improve, especially health is one of the sectors that is is a pioneer in digital transformation. In order to implement this vision of digitization, there are challenges. Yes, there are challenges, but we move forward. EKP, for example, is one of the services that from October we will have the compulsory electronic costing of digital costings. Things cannot happen from one day to the next, but we are towards proper directions, and e-pricing will assist us on how to benefit pharmaceutical industries from the transactions in order to have transparency, to have payoffs right away, and actually complete everything what needs to be completed, so at the end of the day everybody to be happy. We need to have rational allocation of funds. That is why we have the systems and the technology, in order to have transparency and make things more easy and productive for everyone, and see what is happening with the transactions with the public sector. And in health, we need to make haste in order to improve the image. Of course, today we are much better than in the past. Mr. Messaropoulos. DRGs is a rather complex issue. Too few understand it. What could you say to the citizens in order to be able to understand? When I was appointed at the end of 2019, I wanted to communicate what DRG actually is. The first thing that we did to show people to understand this information was the connection with patient's file, so people can understand that whatever necessary information about me wouldn't be a part or wouldn't be included on a paper, but it would be digitized. So if I visited the hospital, they would have easy access to my file, and if I went to another hospital, they would have the same information as well. That would improve a lot the understanding of my conditions. That would also improve quality through this kind of approach. So in Crete, we can see that from 3 hospitals of the region, as we see Crete started earlier than everyone. What they have managed is to be fully digitized in everything, health region, health periphery. Well, in the hospitals of Crete, all nurses have a tablet. Nobody would have imagined that. And in the quality data, because whenever we have hospitals a part of this digitization, we check all the time quality data, and the data we get from all health regions that have been used, and we use them thoroughly to give us data, quality data that will change the whole map. If we check everything and we put quality, we need to put quality. There is a memorandum of cooperation with the insurance companies. Because of the burden in public hospitals, the project is lagging behind, but all those hospitals it is important to take advantage of all this data. The main reason why we do all this is to be able to compensate hospitals for their operations objectively. So if two hospitals do exactly the same work, should be compensated the same way. If we see well, right now we compensate hospitals for their expenditure, not for their quality of services. If we have two hospitals, one spends more, the other spends less, but they have the same quality, the same number of patients, more or less. The one that is benefited is the one that spends more. No, that will change. The bonus will be to those that will have now a rational operation. But we have some people saying that these hospitals that do not properly operate, we will be deprived of funds. No, that will not be true. The state will cover the gap of financing in order for all hospitals to be sustainable. But what we don't accept is spending money without having an effect. By comparing two hospitals offering the same services and one spends more than the other, that is unacceptable. This model of using private hospitals as well, will that change, well, things? Well, we can, well, administratively, by changing certain legal persons of public law and make them private law is not difficult to do. A private entity can offer you more, but in order to bring change, you need to do more than that. We need to find a way for hospitals to operate better, and there we need something more important than changing a public entity into a private one. There are some thoughts, but we need to achieve interoperability nonetheless, and not this kind of changes. Beyond ODP, you have worked in the university as well. We have heard the university saying that we need reforms, etc., etc. Do we have the tools to assess all these changes? Today, in order to be frank, we have more tools than before.
I agree with Ms. Carpodini that the main problem in the health system is the models. We have data that are not easily accessible. We do not have interoperability. There is no reliability in their management. So we understand that any such effort becomes even more complex. So essentially, we confirm what we have been discussing. The hospital map of the country is not rational. It was created years ago with some criteria which are now obsolete. What we want to do rather, we can understand that the problem is that we haven't seen until now the actual health needs of the population. We do not exactly know what type of services we offer in terms of quantity and quality. So we have to do this. We need to become patient-centered as soon as possible. People from Livadia, for example, come to Athens. They do not have a hospital beside them. You can understand that for major surgeries, for example, we need to have major central hospitals. We cannot have a hospital in every village. But of course, we need to have health centers that provide safe services to all. We provided financial motives, and we set criteria for the skills that the doctors should have. Allow me to say that the system is necessary, and the system needs all specialties, all types of doctors. So we try to see how the hospitals will work. So in scientific ways, it's going to be they are going to be connected. So we want proper training, know-how. We don't want to burden the citizens for their chemotherapy. We don't want to drag them to Athens. We want to be sure that we have the same scheme in all hospitals near their home. It's important to change the structure and the legal person of the hospitals. The legal framework has started already, but it needs to solve some more problems.
Ένα νοσοκομείο που έχει μικρότερη πληρότητα, που δεν αντιμετωπίζει.
I consider that all the last couple of years we have made very important efforts in order to provide data-driven strategic planning. Otherwise, AOP and the hospitals and the pharmaceutical companies cannot work. It is different to see to know what you have, and to change, and to understand how you can become better. We want to wait for a while to see which will be the European regulation. We want to see which are the services offered to the citizens via this European guideline. We have, in some countries, for example, UK, we have digitized services for 20 years. We started just 2 years ago. So we want to see what are the needs and how to cover them. So we need to utilize the databases that we have. And then we'll see how we can proceed with digitization of the structures. Now the structures are not even connected with each other. For example, we have no connection in between neurological centers at some towns with a surgeon.
Πάρει τη θεραπεία του. Η διασύνδεση λοιπόν όλων των νοσοκομείων με τα κέντρα αναφοράς.
So we need to create networks and I think that the telemedicine network is also important to cover remote areas. So training, technology and new structures, that's what we need for a very well interconnected system. This is how we can deal with all the challenges that exist. One last comment with a positive comment. Interconnection of the hospitals by IDICA. The tender is over, and now we'll have a horizontal connection in between all the data. This will be under IDICA, nevertheless. The regulation foresees the creation of secondary platforms for data administration.
στο τελευταίο πάνελ θα το συζητήσουμε αυτό. Θα είναι και η κυρία Τσούμα εκεί, θα είναι και ο κύριος Στηρέος.
Η κυρία Τσούμα είναι λοιπόν μέρος αυτής της πρότασης.
Μπράβο, ωραία. Έχουμε λίγο χρόνο στη διάθεσή μας. Θα κλείσω εδώ τη συζήτηση. Κάποιος αν θέλει να κάνει κάποιο σχόλιο. Μικρόφωνα έχουμε. Έχουμε, νομίζω. Εδώ ο κύριος Παπαναγιώτου μπροστά. Μια στιγμή, κύριε Παπαναγιώτου, να σας φέρουν μικρόφωνο.
Αν μου επιτρέπετε
ναι, το μικρόφωνο. Παρακαλώ.
Μια μικρή παρέμβαση όσον αφορά τις απομακρυσμένες περιοχές και τις εσωτερικές. Πέραν του 20%, θα μιλάω πιο μεγάλο φωνά. Λοιπόν, πέραν του 20%.
Apart from the 20% mentioned as for the safety margin for the ministry, we already have a specific variable for remote areas and university hospitals. Specialization is very important. Of course, this way the ministry can guarantee safety. Question, Papanagiotou, medical professor at the University of Athens, and I work with a German hospital. Let me say that I have worked as a director in Germany, and good administration is A to Z, is the most important thing for a functioning hospital. Efficient allocation of resources in between the clinics is very important. And we need to know what type of personnel we need. So it is a very important tool to have case mixes brought in from all the clinics every week so that we can administer all data and we know exactly what every clinic is doing. The monthly reports from the hospitals are important because they give us the view of the processes in each clinic, and we can know which ones are lagging behind so as to support them. We have huge volumes of data, so we are obliged to use the DRGs. That's why KPEGNI is the responsible body for any medical information. Okay, thank you everyone. There's no more questions. There are no more questions. There is a question. Petmezas, CEO of Emetuan. Is there any plan about procurement systems of the hospitals? We know that the SEDs is up and running with regards national procurements, contracts. 80% of the cases is with external contracts. I heard about electronic ordering. What does this mean? Do we have platforms or do we just send PDF via emails? No, we use a platform. We do not upload the order. It's a platform which is then executed. The order is then executed on the platform. As regards hospital procurements, that's an ongoing discussion. Or maybe we can promote other platforms. We've had long discussions with the Ministry of Commerce. In some cases, hospital procurements are different than the procurements in other public sector areas. So we want to see whether we can have our own software, proprietary software, maybe utilizing RRF financing. So let's finish with our panel. Thank you, everyone. We have a short break. Instead of 40 minutes that we had in the agenda, we'll have 15 minutes break to come back sooner.
Για περισσότερο από έναν αιώνα βρισκόμαστε στην πρώτη γραμμή της έρευνας, ανακαλύπτοντας φάρμακα, εμβόλια και καινοτόμες λύσεις υγείας που κάνουν τη διαφορά στη ζωή εκατομμυρίων ανθρώπων. Ακούμε τις ανάγκες των ασθενών και λειτουργούμε υπεύθυνα ώστε να διασφαλίζουμε πως οι θεραπείες μας είναι προσβάσιμες σε όσους τις χρειάζονται. Δεσμευόμαστε ότι θα συνεχίσουμε να εργαζόμαστε για ένα υγιέστερο, φωτεινότερο μέλλον για όλους. MSD. Inventing for Life.
The way we see it, the impossible
is not impossible.
The impossible is simply what hasn't been achieved yet.
So we pursue it.
We chase it down.
We tackle it for answers.
We surround it for a way in.
This is how every once impossible breakthrough has ever been created.
A revolutionary approach to cancer therapy.
A path to a cure for HIV.
A cure for hepatitis C.
A better, healthier world for every person to live in.
None of this is impossible now because of the people you work with.
The communities we stand with.
And the partners we push forward with.
Together, we've created what's possible through science,
grit,
compassion,
and courage.
And we will do it again,
no matter what.
No matter the stakes.
No matter who says we can't.
When faced with the impossible, we don't falter.
We band together and we prove it wrong.
The impossible
is not impossible.
It's what's next.
C'est notre futur.
우리가 다음에 해야 할 일입니다.
قدم بعدیه.
ano ang susunod.
Es lo que sigue.
呢個就係我哋嘅下一步。
It's what's next.
Tomorrow is a promise, the promise of a new future, of successes earned, as we promise our customers to help them drive healthcare forward. Our customers are inspiring us to reimagine how healthcare should work, where human ingenuity can finally unleash the power of ever-expanding health information, analytics, and technology. Where clinical trials are designed around the patient, where predictive analytics prevent medical errors before they happen, where all healthcare players work together to make patients' lives better, where every medical decision is informed by evidence, where treatment costs reflect the value they bring, where precision medicines seamlessly find their way to the right patient. It's the promise delivered by mobilizing unparalleled data, analytics, technology, and expertise, connecting stakeholders to improve health around the world. The promise rooted firmly in data science and domain expertise, the promise of the future.
At Janssen, we are called to rise each morning and achieve today what last night seemed unimaginable. We are called to blaze paths where others fear to go, to unravel and repair the very code of life, to treat, intercept, prevent, and cure. We are called to open our doors to collaboration and our arms to the needs of each patient, so that what works in our labs also works in their lives. We are called to advance how medicines are made and made accessible around the world. We are Janssen, the pharmaceutical companies of Johnson & Johnson, and we are heeding the call. Bravely and boldly, fighting sickness with science, improving access with ingenuity, and healing hopelessness with heart, until the world's most daunting diseases are found only in the pages of history books. At Janssen, we're creating a future where disease is a thing of the past.
Every crisis provides the opportunity for a breakthrough. In 1849, we made our first breakthrough, an inventive and groundbreaking way to treat parasites. We discovered how to get life-saving supplies to the Union Army. We broke through the barriers of mass production, making penicillin and other antibiotics accessible on a massive scale.
The life-preserving drugs known as antibiotics met the challenges of war.
And contributing to one of the biggest life-saving measures of the 20th century.
We're entering a new era of medicine in which the natural lifespan may be greatly expanded.
We fought polio with an oral vaccine, so millions of children could be children again. We innovated a needle that would be one of the key tools in eradicating smallpox.
The disease has been wiped off the face of the earth.
We took on some of the greatest causes of pain, illness, and early death and fought them with treatments that improved the quality of our hearts, bodies, and even helped the way we love. We harnessed cutting-edge science to create breakthrough therapies that help people with cancer live longer. And now, we have broken through the biggest health crisis of our time. Over 170 years of breakthroughs, and we're just getting started.
You've always been told you have potential. But it's not enough to just have it. You need to feel it. It takes time, sweat, and tears. Some wins. Big wins. It takes a we never settle attitude. It takes work, teamwork, hard work. Repeat, repeat, and repeat. To be shaken, to be awakened, to test your limits. Overcome your fear of failure. It's a step closer to success. Look closely at the possibilities. Keep pushing your mind and body. Whether you're on the tracks, in the labs, or in midair, find your potential. Ignite it.
All over the world, people are waiting for innovative medicines for the treatment of diseases with unmet medical needs. At Astellas, we are united in a common purpose. We will continue to provide innovative pharmaceutical products that address unmet medical needs in order to deliver a better tomorrow for patients.
To contribute toward improving the health of people around the world through the provision of innovative and reliable pharmaceutical products. This is our raison d'être. This is why we exist. To continuously contribute to the needs of society, we must look 10 or more than 20 years in the future and never stop pursuing innovation in everything we do. We'll generate innovation by treating external environmental changes as opportunities to bring value to patients around the world. Our vision is clear. Astellas stands on the forefront of healthcare change, turning innovative science into value for patients. We are changing tomorrow.
The EU is falling behind other regions of the world in getting new treatments to patients, securing R&D investment, and attracting talent. It takes 426 days to approve a new active substance in Europe, compared to 244 days in the US. Expedited pathways exist to accelerate approval of promising treatments, but Europe is not realizing their potential. In 2021, the European Medicines Agency used expedited pathways for just 9% of new active substances. In the US, that figure was 71%. This means slower access to new medicines for European patients. Europe's share of global clinical trials is also in decline. Compared with an average of 25.6% over the last 10 years, Europe accounted for only 19.3% of global clinical trials in 2020. This means that patients in Europe are not able to take part in groundbreaking research being carried out elsewhere. The situation is most acute for the therapies of the future, CAR-T, and advanced therapies medicinal products. Since 2020, CAR-T trials have almost tripled, but only 2 in 10 clinical trials happen in Europe. And during the past decade, Europe consistently hosted the lowest number of ATMP clinical trials compared to the US and China. Aware of the importance of the regulatory framework for its competitiveness, China has hired 1,000 people in 2022 to increase their regulatory workforce. To attract greater research investments and clinical trials in Europe, our regulatory system needs greater capacity, agility, and to be more streamlined. We have put together the regulatory road to innovation, a 12-point action plan to do just this. Don't let Europe fall further behind. Back innovation in the EU pharma legislation.
Για περισσότερο από έναν αιώνα βρισκόμαστε στην πρώτη γραμμή της έρευνας, ανακαλύπτοντας φάρμακα, εμβόλια και καινοτόμες λύσεις υγείας που κάνουν τη διαφορά στη ζωή εκατομμυρίων ανθρώπων. Ακούμε τις ανάγκες των ασθενών και λειτουργούμε υπεύθυνα ώστε να διασφαλίζουμε πως οι θεραπείες μας είναι προσβάσιμες σε όσους τις χρειάζονται. Δεσμευόμαστε ότι θα συνεχίσουμε να εργαζόμαστε για ένα υγιέστερο, φωτεινότερο μέλλον για όλους. MSD. Inventing for Life.
The way we see it, the impossible
is not impossible.
The impossible is simply what hasn't been achieved yet.
So we pursue it.
We chase it down.
We tackle it for answers.
We surround it for a way in. This is how every once impossible breakthrough has ever been created.
A revolutionary approach to cancer therapy.
A path to a cure for HIV.
A cure for hepatitis C.
A better, healthier world for every person to live in.
None of this is impossible now because of the people you work with.
The communities we stand with.
And the partners we push forward with.
Together, we've created what's possible through science,
grit,
compassion,
and courage.
And we will do it again, no matter what.
No matter the stakes.
No matter who says we can't.
When faced with the impossible, we don't falter.
We band together, and we prove it wrong.
The impossible
is not impossible.
It's what's next.
C'est notre futur.
우리가 다음에 해야 할 일입니다.
قدم بعدیه.
ano ang susunod.
Es lo que sigue.
呢個就係我哋嘅下一步。
It's what's next.
Κυρίες και κύριοι, παρακαλώ πάρτε θέση για να μπορέσουμε να... Ευχαριστώ θερμά. Ξεκινάμε την δεύτερη ενότητα.
We're ready to start with the second session of our conference, and we are asking Mr. Olympios Papadimitriou to come to the floor from the Association of Pharmaceutical Companies in Greece. Mr. Papadimitriou. Good morning, ladies and gentlemen. Good afternoon, rather, says the speaker. Let me thank once again the organizers of this conference, and also Mr. Nigis as a moderator. I'm here to represent the Association of Pharmaceutical Companies in Greece. The aim of this short presentation is to speak in brief about the priorities of our sector in relation to the pricing of drugs in the next years. My father used to say that when repeating something, you learn it better. So I'm afraid that I'm going to repeat, maybe not 100%, but at 90%, things and priorities that we have mentioned in the previous years as well. Instead of solving these issues, as we understand, we are making the problems worse. Maybe it is us to blame because we're not explaining ourselves well. Or another answer could be that the other parties are not interested in what we say. Nevertheless, here we are in a crossroad with a new government, continuation of the previous one, but with new persons in the ministry, and we hope that under these circumstances we will have a better future in the medicines sector in order to solve these problems that have burdened us for more than 10 years. Now we are 5 years after the memorandum period. We are now a free economy and we are doing better. So, in order to prioritize, we can say that we have 6 basic things. This is the one and only slide that I'm going to show you throughout the day so that we can absorb the 6 pillars better. It's important to rationalize pharmaceutical investment in drugs because expenses here means that we invest in a better future for our citizens, a better health. Let me say that I believe that it is immoral to say that 70% of sales can return back to a company in the first semester of 2022 as regards hospital expenses, hospital expenditure. Actually, this means that there is no rational way to provide medicine into the market. There is a necessity for funding, and it is important to carry out this in a fully regulated environment as the public hospitals. Also, we have an expense for those citizens who don't have an insurance. In 2022, this expense is 300 million euros, which is 10% of the total. An assumption here is that something is wrong. Do we have more diseases with uninsured persons? On the other hand, the Institute for Pharmaceutical Research and Technology, which covers needs for medicines that are not in the market, have reached a turnover 200 million. This is one of the fastest growing sectors. And the question is, where could this stop? In my opinion, it's not logical that we cover these types of expenses from other budgets for medicine. And we should also consider the European trend, showing that 6 to 7% is the annual expenditure for drugs in Europe. The numbers are a bit better in the last couple of years, but nevertheless, we don't see an increase in public expenditure for drugs. So this means that this is an ongoing problem that has to be dealt with. These priorities are very well connected with each other. The system should optimize the existing resources. We speak about medical files, and we need to have rationalized resources. So when are we going to have all these? We haven't seen any digital restructuring that gives an optimal resources management. So this way, we can ensure that all citizens will have access to the newest and most modern therapy treatments without any delays. The pharmaceutical companies try to keep some drugs in the market because with rebates of 70 or 80%, the market might deteriorate fast. It is important to convince the administration to have a fund for innovation, for revolutionary treatments, for example. It is necessary that we have this in our budgets. In the last few years, we have seen a tendency to rationalize the framework. However, we need more and more rational criteria. We have investments from the Greek industry. These are good investments that could be drawn into Greece, but we just see a 5% settlement in the RRF framework. We believe that these could reach 200 millions or 500 millions. But let's focus on how we can balance based on the motivation, on the incentives that are already in place. We need to see how this can be used further. Also, we need to consider the reform of the European drug policies that takes place. This is a complex matter, and we need to support pharmaceutical innovation and research so that we have more drugs in Europe and more monies for research. Any opposite move will decrease the prestige in research and development We are a small player in Europe. And our country has to speed up. The previous administration of the ministry was openly in favor of keeping good intellectual property protection framework for research and development. So in conclusion, I would like to speak about something which seems necessary, and it regards the operability of the system. It is illogical to have negotiations about products that have been closed in previous years. This is important for the ministry in order to cover the clawbacks. However, this is not healthy entrepreneurship. Here we do not have any negotiation but it's a policy of premature returns. When I started speaking, I spoke about the clawbacks of the first semester of 2022. We have done a lot of discussions with previous ministries. You need to be a mathematician in order to understand which is the equation determining the discounts and the clawbacks that the companies have to manage, with certain exceptions, with certain special regimes, with certain protected keeps, DRGs. So, as I said in the beginning, I am going to repeat all the challenges that we still face after so many years that we have been discussing the problems. We all want to cooperate in order to have a better health system, but it's difficult if we don't cooperate. Thank you very much for your attention, and we hope that we'll have a better future.
Let's thank Mr. Papadimitriou. Mrs. Labrina Berbelaki is the next speaker. Chair, Pharma Innovation Forum Greece, and CEO of the AbbVie Pharmaceutical Greece, Cyprus, and Malta. So, good afternoon, everyone. I would like to thank the organizer of this conference, in which we have the opportunity to talk about the challenges, opportunities, and for something we keep forgetting, what all these things mean. I would like to say that we talk about medicines, pricing, medicine policies, but let's talk about what we pay in innovation as an investment. Let's talk about the value of innovative solutions. What does it mean by starting from the system to the beneficiaries? What have we done as therapeutic innovation? It has contributed with three benefits to patients. Increase of life average. More than 10 months have been added for Greek citizens within the last 10 years. We have managed to be able to talk about eradication of diseases, or some 8 years ago there was no cure, and now we talk about eradication. We have found therapeutic solutions that talk about different standards of care, totally different standards of care, innovation with designing, planning. We talk about cancer as chronic disease. What does that mean? Well, I can give you some clues. We have increased the life expectation by 5 years in oncology, in immunization. We have made steps forward in neurology, a lot. In Parkinson, Alzheimer's, we have taken also steps forward. And now the third pillar, a more healthy society, which is quite important. What does it mean? The prosperity of people makes people part of the economic system and the society. People can work and contribute.
Με τα 10 χρόνια με βάση το Horizon Scanning να φέρουμε την καινοτομία.
What does it mean to bring innovation? It means that we need to find more solutions to this category. We need to be sensitive towards innovation in order to be able to do that. That is the only one part of the problem. Let's talk about the value of therapeutic innovation for the system per se. Sometimes we praise all these services, but what services can we predict and be more ambitious? A lot of changes have taken place. We offer and we subsidize. When we talk about negotiations, behind these businesses that bring innovative solutions, they offer new services supporting patients, devices, auxiliaries, the delivery of medicine. It can also be a point of view of how you can facilitate diagnosis, screening, support of caregivers, nurses. We must never forget these are basic services, and of course they are promoted by the national health system, but innovation also comes from the pharmaceutical companies. Cost saving, synergies, and avoiding costs. Of course, we don't want to burden healthcare system if not needed, to have better use of emergencies, to have less days of hospitalizations, and the better use of man and technical personnel and materials. And this is promoted by innovation. Every time we take a leap to increasing life expectancy, we help towards this direction. The third part, the previous speaker talked about skills and a smart system, health system. We have an offer there as innovative in industry. We can talk about the value of data for the patients to be able to talk about accuracy, the training of doctors and patients who want to promote their health, to talk about cooperation with research centers, universities, hospitals, to offer real work evidence. And as innovative industries, we have networks in all over the world. We can bring practices, and we can do that because it promotes science and health. Innovation is a lever of growth. We must never forget that it brings growth. It is an investment, it's not a cost. A lot of these figures you might have heard, and I agree with the previous speaker. Let's talk about what we offer as an industry, not 123,000 jobs, but all those who work with us, researchers, consultants, who are involved, the GDP contribution, the figures are there, but we talk about more things, investments in research. 100 million are not enough. I think that we have best practices and we can take a step forward. We talk about an innovation space, which is an ecosystem. We don't work in silos, for example, offer products to the market and price them. We cooperate with technology startups, and this alone is a factor of growth. We look into the future for Greece with even greater growth, and we want to have a pioneering role in that. So when we talk about investment in innovation, we're not talking about policy alone, but something that bears more fruit. So I would like not to repeat what has been heard since early in this morning, but remind you that in order to have all this offer, investment, the continuation of this job, we need to have an environment that could allow conditions for growth. I need to remind you, and based on clawbacks, etc., 7 out of 10 medicines are offered by us. We are co-sponsors, and if you wonder that this is the case to other countries, this is the case for other countries as well. We are by far contributors compared to others. We need to revise this policy. It was mentioned by previous speakers, and now what? Now, after all these years, there are a lot of therapeutic solutions that need to be brought to the patients. When we need about access of patients, we're not talking about by exception, access by exception, but we want all patients that are in need of this innovation and can be benefit by it to take it and not lag behind. This is what we actually ask. As chair of PIF, representing 26 companies embracing innovation, I would like to talk about three parts you have already understood from this discussion that are necessary. It is necessary to talk about financing in order to cover the needs of the patient and, of course, to find innovative solutions. Yes, Innovation Fund was already mentioned. How can we assess innovation? What are the priorities and how we can help with that? Let's see. At the same time, we need to see structural changes. We need to support as well in order to have allocation of resources, fair allocations of resources, pharmaceutical protocols, the way we can introduce changes and controls. We're here to discuss. I don't think industry wants a non-rational use of resources, but these resources need to embrace the needs of patients. Last part, we're talking about the data, digital transformation and opportunities that have been initiated. Let's see the next step. We need data. We need to talk about innovative funding, and we need data, and we need to discuss about real needs and objectively calculate how patients are benefit, how we can increase the performance of our medicines. We're here to discuss, and I would like to say something else. How? We don't have to talk about everything in a meeting. We need to promote dialogue, lifelong dialogue, and find solutions in a dialogue full of transparency. We want to embrace this kind of dialogue. We are at a crossroads. A lot of changes are ante portas. But if I want to leave you with just one message, let's not talk about one medicine alone. Innovation in our industry is not something that is just an idea. It's something that can be done in practice. Mrs. Varvetaki, and now Deputy Minister of Health is invited to the podium, Mr. Marios Themistokleous. Hello, good morning everyone. I would like to thank Mr. Negis for the invitation to participate. From a new post compared to the previous years. Last year I was there for the primary health sector, personal doctor, etc. I don't want to be tempted to talk about pharmaceutical policy, etc. You have heard a lot. With the new government, you will have the opportunity to discuss further things. I will touch upon my topic, secondary healthcare and supervised agency. I will give you the outline. The main pillars of that is manpower, infrastructure, and as said earlier, digitization of health care system that will take us to the future. There are not easy or difficult solutions. There are difficult and more difficult ones. In the next 4 years, more than 1 billion euros will be invested in upgrading healthcare system. The first funds have already been allocated. With TAIPED, we are going to renovate different departments of hospitals and iconic, if we want to say, creations as it is the X-ray department in Sotiria or blood department in Papanikolaou. By the end of 2025, we have renovated the majority. We will have renovated the majority of the healthcare centers in Greece. We will support all these solutions that will bring a new day to the upgraded primary health care. And we will have Stavros Niarchos new hospitals, and we will have funds for refurbishing the different departments in hospitals that will cost 1.1 billion euros. Equipment, we will upgrade, modernize equipment in primary healthcare and secondary healthcare. And manpower, which is the most difficult part we need to invest in. As the Prime Minister has already announced, we will have 10,000 new jobs covered. We will hire 10,000 people in the next 4 years. The procedures have already started, and then we need to see the doctors' working conditions. We have voted a law, and we will try to upgrade structures and all kinds of relations. We have different problems on the mainland and the islands. And with regard to digitization, we will have the digital patient file, 40 million. All these works have started. The tenders are there already. Under the umbrella of the main project, 40 million in upgrading digital tools of hospitals, the oncological e-file, the tender has finished, and we will increase the number of telemedicine in the country. 800 new telemedicine centers. All these things will improve the work of health professionals. I will mention some of the agencies of the Health of Ministry, EKP, managing procurements and other agencies that focus on procurements for medicines. We want to have centralized procurements with a specific roadmap in the years to come. The second organization is Ketekni, which will introduce fully DRG. We need to be practical and not theoretical. This is a substantial change in the administration of hospitals throughout Greece. A third organization suffering a lot lately. It receives pressure from various factors, is ECAV, the ambulance service, which needs a restructuring with creation of new sectors, restructuring of forces, retraining digital systems in order to reach the times of response and quality of services of similar organizations abroad. I need to acknowledge the efforts of the previous administration. It was an inspiring administration, and we are there to fulfill the vision and enrich it, especially in healthcare units, emergency units, and ambulance services. Whatever I have said here is not something new. You have already heard everything during the election campaign. I am here not to talk about things, but to make things happen. I will discuss with all stakeholders what we need to do. I'm not a man of words, but of action. We need to negotiate with stakeholders in order to implement things to the benefit of all. For the next panel, I would like to invite Dr. Athanasios Exadaktilos, Mr. Kapetanakis, Mrs. Vicky Ikonomou from Janssen, and Kyriakos Souliotis from Professor of Health Policy of the University of the Peloponnese. Take your seats, please. Okay, perfect. Are we all ready?
Ναι, αυτό λέω, εκπροσωπώ το γυναικείο φύλλο, Κυριάκο, γιατί χρειαζόταν.
Ναι, δυστυχώς ή ευτυχώς, όπως στην κυβέρνηση είναι, πώς το λένε, απόφαση του Πρωθυπουργού, εδώ αποφασίζω εγώ, αλλά τέλος πάντων διαλέγω από τα... Ο
Πρωθυπουργός θα βγει λίγο καλύτερα.
Ναι, σίγουρα. Ναι, ακριβώς. Θα ήθελα να ξεκινήσουμε την...
Let us start our discussion with Mr. Kapetanakis. We want to satisfy the patient's needs. We have a new government, which is the continuation of the previous one, of course. So, in brief, I would like you to speak about your area. What are your expectations? Thank you for the invitation in this panel. You have excellent participants, and we understand very well that a lot of work has been done already. Representing the oncological patients, we will focus on the better treatments and in all dimensions. And we want to cooperate with all organizations and create together with them a better future. First, access, meaning that access is very important. It is also important to have innovation in access, rather access to innovative treatments. This is important if everyone has access to innovation. So it's important and valuable to have access to innovation. I know that several steps are taken, and we need to face all the challenges. Some steps have been taken already, and we can do some more. For example, we cannot speak about cell treatments without having a framework for indicators. How are going to approve bioindicators, for example, and who will have access to such innovative treatments? Recently, The Institute for Health Finances drafted a proposal that this could take place, and AOP could handle this. These are small steps which can realistically happen. So we might set new frameworks. Another dimension is quality. Mrs. Kaitilidu mentioned the very good work that has already been done at the level of the ministry with the infrastructure. However, we want to improve access of patients to high quality treatments. I know that all these steps will function in the future. It is interesting, Mr. Kapetanakis, that the government, for the first time, has introduced some quantitative indicators to measure efficiency of the programs. Waiting times, for example, for cancer treatments. We need to know which are the current situations so as to improve them. Yes, you're right. Many times since this morning, we spoke about data access. It is indeed a problem, but we want to do something more. We have the bright side as well. I am very much enthusiastic that we have started taking stock of the good practices in the hospitals. The administrations can record what are the good things that happen in the hospitals. So at the end of the year, we can know what we achieve. So maybe these good things can help us shape a better future. This is very important. Excellence is another dimension. The governor mentioned about excellence. We used to speak about machines in the hospitals. Now we do have machines, and we want to have the drugs as well, and we want to have access for everyone with the lowest burden and with the highest quality, the best service. So these are issues on which we can cooperate with the organizations as an association, as a federation that we are. And we can see which are the vacancies. Let me give the floor to Mr. Exadaktylos, plastic surgeon. We've seen the Ministry of Health conducting surveys every year in order to see what happens and implement and evaluate their own work. With 10 or 12 questions. Can you please tell us which are the findings of these surveys? Thank you for the invitation. Let me say that as a Pan-Hellenic Medical Association, we conducted the second survey in 2023. The first one was in 2020. After that, we had the pandemic. And now we'll have one per year. We conduct these surveys because we want to see if the society understands what we do and they understand which are the problems in the health sector, and also we want answers to some questions. With the first thing to say is that satisfaction is higher, a little bit, but it is higher than it was 3 years ago, by 8% after the pandemic. The second finding is that in the past we had the personalized element. They want a good doctor and they want to have a say on which doctor they select. The third thing is that the proposals that we have submitted were positively accepted. Acceptance ratio ranked from 70 to 95%. We have questions for the general public, and we also have questions for the health practitioners in our surveys. What is important is that it seems that there is a misunderstanding in the terms that we use in our daily life, because we have seen that 85% or 90% is against the change of the legal status of hospitals in turning them into private law public entities. As it is, the Onation cardiosurgery hospital. But they are satisfied, though, from these hospitals. So it seems that they do not understand what the term private law legal entity means. So we need to find out which are the misunderstandings of the general public and explain to them what we mean. These were my impressions. So the first thing, Mr. Themistocleus, is that you have to communicate the proper meaning, the proper content of these concepts, so that the general public understands the targets of the government. Of course, I understand that the word private is a hot potato for Greeks. For example, if I say I have a red rose, everybody likes red roses. But if I say a private red rose, everybody would say no, I do not like them. So it's very important to explain what private means in this context. From the creation of the national health system, we haven't had acceptance of public structures that carry out all types of operations, of functions. COVID played an important role to this. The public structures during the last decade have become stronger. Everyone was vaccinated, everyone was treated in public hospitals through the COVID period, and everyone was satisfied. So this is an issue for the public dialogue. The second thing would be to speak about what the private structures have. For example, the Onation cardiosurgery hospital, what does it offer to the people? So they can understand what private law public entity means. I visit all constituencies often, and I have a discussion with all the stakeholders. They need to understand that the hospitals will not change, will remain the same. Only the legal status will change for administrative reasons. We have resistance at the communities, but they need to understand that the hospitals will not change. In the next months, we're going to have to issue some announcements. So we invite everyone, the opposition as well, to focus on the concept of private law legal entity. Sometimes rather, in recent years, we have extended the facilitations that public entities have, so sometimes private advantages can be found in public structures as well. Okay, let me go to another public opinion survey regarding decision making that has been carried out by our next speaker. As a professor of social sciences, what do you think that are the prerequisites for the government? Thank you for the invitation. This whole discussion is very interesting. I am a servant of documented health policy. Every year we conduct surveys in 1,000 households, and we see that our findings are almost identical with the findings of the Pan-Hellenic Medical Association survey. Everyone goes to a private pharmacy to take their drugs, their medicine, and they don't care. So actually resisting the private hospitals, the private character of a hospital is an avoid letter. This is an obsolete discussion, actually, I believe. The citizens want to have the freedom to choose. It's very important for them to choose, because this way you can go to the person that you trust. I go to the pharmacist that I trust or to the doctor that I trust. And that's important for the people. Secondly, accessibility is an issue. Where do we have a good access? In drugs, in diagnostics? The clinical doctor, the general practitioner, is a problematic, though. In the first two dimensions, we have contracts with all private stakeholders. In the GPs, in the case of GPs, we do not have contracts. So this shows that the contractualization is an important vehicle for the smooth progress of this operation. So we need to see how to solve this. Actually, we had a very good vaccination program, and we took the tools from there in order to provide contracts with our contracting parties. During the COVID, we saw that the state can do it. Yes, but of course we have made some digital mistakes with building the protocols, but they are simple mistakes. They can be easily solved. There are many pharmacies, but of course consumption is not controlled. I do not agree with this phrase that consumption is not controlled. Diagnostics are controlled at the level of reference.
Πρέπει να κάνει έλεγχο θηροειδούς, ξέρω εγώ. Άρα εκεί πρέπει να...
So we still have some slight problems. I have a different view on this. I believe that it is problematic to have too many doctors. In other countries who have more advanced health systems, they have less number of doctors. We want to see. I would like to see the patient's satisfaction as an indicator. But of course, we have to say that the fees of the doctors, the salaries of the doctors, are too low. They do not reflect the value of this profession for the citizens. So we need to provide criteria, incentives of additional work, so that people work seriously. This is something to discuss. It is necessary. Apart from, in the case of the GPs, it is seen that we haven't managed to attract so many general practitioners because we haven't given many incentives. This is a dynamic situation. In order to make the system more attractive. Now, regarding private and public, we need to explain to the society what is the disagreement of the citizens in the operation of our nation cardiosurgery center. What is their problem actually? You see that the politics are different. For example, every law regarding compensation of the hospitals treats the public and the private ones in a different manner. Yes, but essentially we want flexible schemes with good, high quality of services for all citizens. Sometimes we hear that doctors get their pensions, so we have vacancies. But pensions are something that can be planned. We know that people are going to get their pension and they're going to leave their practice. So we can plan ahead. Or we can keep them if they have the proper incentives. If the legal status gives the state a better tool to administer for administration, then this is positive.
Βλέπω ότι η κατανάλωση φαρμάκων, είδαμε πολλά στοιχεία και νοσοκομιακά και εξωνοσοκομιακά, συνεχίζει η κατανάλωση να αυξάνεται. Τα budget παραμένουν σταθερά. Το μέτρο του Clawback έχει...
Clawback has a horizon of until 2026. After that, we'll return to a normality.
Καταρχήν, να ευχαριστήσω, κύριε Νεγκή, και την Οργανωτική Επιτροπή.
I'd like to thank the organizing committee for inviting me in this panel with distinguished guests. I'd like to go back to normality, the concept of normality. In our environment, we see that things change continuously and we want...
Clawback is came in 2012 after recommendations of IMF, but now we are away from memoranda. We are recognized for our growth, and we are in these memoranda measures. But how can we move forward after 2026? There is no clawback regulation. Mr. Karoukis gave us data. If we leave things by 2026, it means for me that we, in order to be able to implement the commitment of the Prime Minister and the government for a fair, equal and free access for the citizens to see medicines as well. We need to prioritize, we need to prioritize in the medicines as well with regard to what has been decided in the Ministry of Health. It's important all agencies in the sector to sit around the same table and discuss with the heads of the Ministry of the Finance, etc., on how to rationally handle this amount of money. Colleagues in the previous roundtables talk about a lot about clawbacks and etc. But we need to discuss what practically mean these burden. How do these affect the companies, the investments, the personnel, decrease of personnel? A previous speaker said that his company did not bring 4 new medicines in Greece because of this policy. But patients who don't have access to innovative drug that can increase their lifespan at the same time, it is a result to the detriment of the society. What does that mean for the care givers, etc.? Mr. Exadaktilos, about payments of doctors and work conditions. Comments. Yes, I want to understand that there are a lot of things before our eyes, and we tend not to see them, and they create problems. And I will touch upon clawback we have just discussed. We are the only European country. Anyone can go to a pharmacy to buy medicines without prescription, except for categories drugs, antibiotics that are prescribed, and all those in shortage. Well, so those that are in shortage, these cannot be purchased. The rest can be bought. At the same time, we have clawback in medicines. And consumption of a lot of drugs. What prevents us from implementing to what we have introduced in drugs, antibiotics, and in shortage to decrease this expenditure? Well, let's go to the next. We have a problem with the clawback, which was introduced in 12 in order to finish in 2018, and now we go back to 2026. So that means whatever we budget is not enough. So it's not rational to think that we will need more resources in a society that changes life expectancy and medicine gives new opportunity. Even though we have introduced taxes for the environment, the pollutant pays, for example, we don't find a resource like that for health. A sin tax, for example. First of all, we need to rearrange, for example, taxes for cigarettes. If we have cigarettes be bought €4 10 cents instead of €4, that means that clawback will be a thing of the past. And if these 10 cents are given to the healthcare system, well, if we find 150 million, let's see that we have found them, and we find 150 from obesity, foods, etc. But if we don't have structural changes, in a couple of years we will be in the same situation. Mr. Plevris gave more money in the past. We're talking about 60 million. But this is not enough. We need resources, permanent resources, and the state to upgrade them or downgrade them depending on the needs. Well, we will start the pre-symptomatic programs. Yes, but that costs less than screening, than curing cancer. Screening programs are more efficient than curing ones. Clinical doctors are estimated by the state €10 per visit. So what do we calculate €10? The obligation to prescribe a medicine, because if we say that society believes it's rational, it's not. Our research says that 45% go directly to the private sector when they have a health problem. So understanding that they can't find solution in the public sector, and 75% say that they would go to the private sector if they had money. So society is ahead than the political system and the political dialogue. With regard the remuneration of doctors, and we say so, but after I have heard from the Deputy Minister that manpower is 1 out of 3. For us, manpower is all 3. If we want to have 3 priorities for the healthcare system, yes, infrastructure, digitization, yes, but manpower is unique. You talked about jobs, procurements, etc. Will we be able to attract personnel? We have tenders for personnel in various regions, and we don't have interested people. In Syros, for example, the personnel might have job for half of the year, and the rest of the year they won't be doing anything. So, do we have seasonal hirings, permanent hirings? What are we gonna do? We all agree that payments of doctors, remuneration of doctors should increase. We all say yes. We would like to increase the salaries of doctor, but that will change a lot the budget. We also say that public sector in health should go to the average of the rest of EU countries. That can be achieved gradually because we cannot find 4 billion euros from other areas and put them in health without creating deficits in all these other sectors. We need to find the money, but without taking it from other sectors, to the detriment of those sectors. Nonetheless, we all understand that money is needed. That's why we need to find new ways to increase salaries. Yes, the islands have fluctuations between summer and winter. We process some solutions. We will find incentives so that the personnel of mainland would like to go to the islands of the healthcare centers. An incentive was already given of 1,800 euros, but that doesn't seem to be enough. Well, hospitals themselves have real estate to make money, or they could host personnel that come to the island to work. On some islands, local society should facilitate to find houses. This very moment, we want to find a way to solve the ambulance service problems. So, we have tried to give incentives to ambulance drivers to go to the islands. We have procurements from ambulance services on the islands, but there is no interest for people to go there and work. And so we want local societies to help us by finding shelter to those people who work in this. In Santorini, for example, there are no shelters to host people who do not live on the island, who are not inhabitants, because they use everything for tourists. In the past, we spent a lot of money in health, but still problems are there. We have people lying on being in the corridors of hospitals, or we don't have adequate ambulance services. It was mentioned earlier. People, Greeks pay privately for healthcare services. That means that some people can have the money to spend it on healthcare services, but there is 30% of people who don't have the money to pay and go private. We want to find solution for them I will agree with the increase of salaries, but this system now has been consolidated, which means that new money pouring in will benefit the system more, if allowed, of course, by the economy. We say that as economy grows, a percentage of this growth should be allocated to health. So we want to do that and reinforce that a gradual transition can take place. Of course, there is spending. For example, we need to understand how to organize the hospital map. For example, you need to understand what are the needs of various hospitals and rearrange their priorities in order to cover the needs of the society. We need to reinforce clinics in primary hospitals, primary healthcare hospitals. So we need to find a way to solve these issues, and we need to start by the structure of the system. Citizens, after the electorate campaign, have heard promises by the government to find a solution. In a prefecture in Phthiotida, Viotia, there are a couple of hospitals, or Chalkida has a well-organized hospital. So we have a hospital within a radius of 50 kilometers, 3 hospitals within 50 kilometers. If we abolish one of them, because rationally we can, how will local population will receive this gesture? Because we cannot support them. Citizens themselves will come to Athens as well if they have a very serious problem. So they won't go to the local hospitals. This is a very difficult exercise to solve. Societies know that if they have orthopedics in every hospital, practically they don't have. If they have 4 orthopedics in a well-organized clinic, they can drive 7 to 10 kilometers to get there. Doctors are doctors if they exercise medicine. If we don't organize everything perfectly, we will destroy things. In the past, people would go to London to find a cure in certain things. So, a comment I would like to make: it's true that patients want to have all services next door. This is the mentality. We have another perception. We talked about quality. For example, you live in Pieria, so you go to Thessaloniki. We also thought of introducing a new hospital unit in the greater area, but without any study in oncology care. For example, and according to the models already introduced, we see that there will be a central hospital and satellite hospitals around. The structures that operate in various hospitals can be taken advantage of, and I also need to say, since I mentioned Savas earlier, this model could have been developed in cases in pain clinics in palliative care. The piece of legislation has already been voted for lately, and it can produce work. This is an important category. You need to take advantage of patients' associations because they inform their members on how to deal with things properly and not have expectations of other countries. Institutionally, you need to have patients' associations by your side when you need legalization of things. I agree with what has been said, and it's nice to say all this by patient or the Panhellenic Medical Association, because this can be heard better to local society. The decision is one we've been discussing. All these things in our country about restructuring, the hospital map, etc. We need to see what is the priority, and after a while, I think that we will manage. We have 2 or 3 minutes. Any comments or some from the audience? I would like to say that in Europe, America, and advanced healthcare system, decentralized healthcare is the future, and in combination with digitization will allow Greece to move forward. We need to develop that. It is an exceptional initiative with care at home, and find in this healthcare map what other opportunities lie in order for pensions that live on the islands or distant areas to have access in cure. To Mr. Souliotis, who have asked first, I have kept the quantities objectives set by the government. Well, these goals are important. We need to compare nonetheless what are the times today, and to check things at the end of the 4 years. We need to be realistic, and we need to have an annual report. The head of Atikon Hospital has introduced the latest report of achievements for the hospital. So these reports are very important, because if you don't measure something, you cannot know its level, its importance, and how to improve it. We might say, yes, we will do that, but it's empty words if we don't have specific data. We always need to know what I have received, what I have delivered. It's important for all of us to take decisions. Mr. Exadactylos, I will go to the next a topic about personal doctors, etc. I am under the feeling that the discussions we have today for some issues to find ourselves in a situation where things will have moved faster than expected. We want to find structures that serve and cover the needs of patients. Well, Mr. Georgiadis, the lady first. I would like to ask, in the framework that we are interested in lowering costs and satisfy patients, to implement no medicine without prescription, isn't that the important measure that will limit costs? We have seen that when we had campaigns, what kind of medicines people would bring for poor people. Are you sure that the resource a medicine is prescribed is a clinic? I work for 35 years in primary health care and either agency that are directly linked to people. What the Medical Association has already said is important. From research shows that people, 30% of citizens, ask for private services. Have you asked these people if they want to go to a doctor that has a contract of 10 euros mixed? Doesn't it downgrade the prestige, the status, or the service rendered? We need to solve that directly, because people will be satisfied and the state will save money with medicine. AMCA cannot open a medical file and to be able to prescribe thousands of medicines. And Mrs. Anemodora from the Medical Association of Piraeus. And the mic to Mr. Georgiadis here. Hello, everyone. Can you keep your comment for the next table? No, it's something that you have asked as a question. Georgiadis Konstantinos from Atikon Hospital with regard to the islands, summer, winter. we will agree before answering that health is a social good. So I think it's better to have during the winter a couple of nurses sitting there, not only for the summer, where I will definitely need them. It's a question. It's not that we we don't want them to be there. No, it's because they don't go. It was asked summer and winter. So I think that it is nice to give incentives to have personnel all year round. This is a huge problem. We know on the islands the needs during summer are quadrupled. But it's important to have personnel, but not only for the summer, for the winter. You know that people who work in the health sector need to upgrade their skills as well. Mr. Georgiadis, infrastructures on the islands are not only hospitals. Well, in police, why don't we have policemen reacting when they are not when they are sent to the islands? We're talking about public servants, so we have structures. For example, police transfers personnel from the mainland to the islands to cover their needs. But if well, we have to find nonetheless shelters because we had doctors living in the hospitals or in their cars. Well, care at home is important, so we need to find equipments for x-rays, for example, in home care. That would help a CAV as well, and the back and forth of patients who could not move to hospitals. It's something that we have seen in the past with vaccination. It was organized in such a way so as vulnerable population need not transfer. The experience on how we organize things is there. We will have a short break. Don't leave, because we will move forward with the next panel. We will clean the microphones and we will be back in 5 minutes. Thank you.
Τεχνολόγους, ακτινολόγους μας συστήθηκε νωρίτερα από το Αττικόν, αλλά είναι και πρόεδρος της Ένωσης Τεχνολόγων Ακτινολογίας.
We are ready for the next panel. We have Mr. Georgiadis from Attikon Hospital, radiologist, Mr. Dervenis, oncologist from the Metropolitan Hospital of Cyprus, Mrs. Economopoulou from the Hellenic Management Health Services Society, and Mr. Papanagiotou, radiology professor of Athens University. Let me start with my questions so that we understand which is the role of everyone in the discussion. The health is a priority for the current government. However, we haven't spoken about contracts and salaries, etc. Mr. Panagiotou has worked in Germany for years.
Το πώς γίνονται οι προσλήψεις, το πώς αμείβονται οι γιατροί και έκρινα ότι στη σημερινή συζήτηση θα ήταν...
And he has spoken already about the salaries in Germany. You've been working for some years in Greece. So which are the basic points in Germany? How do you compare the two countries? As regards salaries, criteria to hire them, etc. One thing is salaries and another thing is organization. We have 3 managers, for example, for different kinds of functions. So the selection is very important. So the criteria are going to be very strict in order to support the clinics. And then we have the managers who will be very strictly selected by committees with high salaries. We have committees in the region with the participation of the directors of hospitals. For example, according to their specialty. For example, I was in a committee related to surgery. Do you get any bonuses? No, there is no bonuses. And from the ones selected are being visited at their working area, so they can be evaluated. So you shortlisted 3 persons and you visited the persons at their workspace at the hospital. Exactly. We saw the way that they function in the hospital, in all their processes. Also, we saw surgery. After the selection of the first, then negotiation with the administration is free. We have to see that all criteria are met, there is financial efficiency, and also we understand that any moment that the criteria are not met, they will have to retire from their post. So we have a continuous evaluation of the work of everyone. So we have evaluation, good salaries, and good and independence in negotiations. They negotiate their fee with the administration of the hospital.
Κάποια κρατήδια που είναι λιγότερο πλούσια και αναειδικότητα βέβαια. Υπάρχουν ειδικότητες που προσελκύουν πάρα πολλές ιδιωτικές ασφάλειες. Αν δηλαδή μια κλινική έχει από την ιδιωτική ασφάλεια, γιατί το δημόσιο εκεί πληρώνεται από τις ιδιωτικές ασφάλειες και είναι ένα κίνητρο να προσελκύσεις ιδιωτικά ασφαλισμένους ασθενείς, θα παίρνει ένα μερίδιο και ο διευθυντής και οι επιμελητές.
Ωραία, η επιλογή έγινε και η αξιολόγηση του ιατρού, ο γιατρός αξιολογεί το υπόλοιπο προσωπικό της κλινικής του.
Ναι, κυρίως αυτός είναι υπεύθυνος. Δηλαδή, του δίνεται εκεί η ελευθερία. Όταν ανέλαβα εγώ το τμήμα, η διαπραγμάτευση δεν έχει να κάνει μόνο με τον μισθό, έχει να κάνει με το τι θέλεις, τι εξοπλισμό χρειάζεσαι. Εγώ ζήτησα 3 επιμελητές δικούς μου που ήρθαν μαζί με μένα για να ξεκινήσουμε ένα καινούριο κέντρο. Δηλαδή,
άρα το νοσοκομείο προσέλαβε ομάδα.
Προσέλαβε ομάδα. Από τη μία μέρα στην άλλη. Έτσι.
Μάλιστα.
Από τη μία μέρα στην άλλη.
Και εσείς αξιολογείτε και το υπόλοιπο προσωπικό της κλινικής, δηλαδή τους νοσηλευτές, τους τεχνολόγους.
Ναι, εντάξει, εκεί υπάρχει μια αξιολόγηση, υπάρχουν μόνιμα συμβόλαια, υπάρχουν και συμβόλαια τα οποία είναι διετή, τριετή, οπότε στο τέλος αυτής της διαδρομής μπορεί κανείς να αποφασίσει αν θα ανανεωθεί ή όχι για τον εργαζόμενο.
Άρα υπάρχει ένας πυρήνας μόνιμου προσωπικού και υπάρχουν και ενδεχομένως κάποιοι που έχουν σύμβαση.
Συνήθως αυτό που γίνεται είναι μετά από ανανεώσεις διετίας, τριετίας, μετά από κάποια χρόνια μπορεί να δοθεί και μόνιμο συμβόλαιο σε κάποιον, όπου υπάρχει η πλήρης μονιμότητα είτε γιατρού είτε νοσηλευτή ή τεχνολόγου.
Ναι. Να έρθω σε εσάς, κύριε Τερβένη, έχετε χρόνια, ίσως δεν σας γνωρίζουν, χρόνια στο ΕΣΥ, έχετε υπηρετήσει και σε γραφείο υπουργού, διευθυντής, αλλά σίγουρα για τη σημερινή κουβέντα είναι κρίσιμη η συμμετοχή σας σε μια ομάδα στελεχών από το χώρο του ΠΑΣΟΚ που είχαν ως στόχο τον εξυγχρονισμό του συστήματος υγείας. Κάνατε από παλιότερα κουβέντα περί του απαρχιωμένου θεσμού της πλήρους και αποκλειστικής απασχόλησης κτλ. Τώρα εργάζεστε στον ιδιωτικό τομέα. Δεν νομίζω ότι τώρα, θέλω να πω, δεν έχετε κάποιο ρόλο στα πολιτικά πράγματα, αλλά μπορείτε να μιλήσετε λίγο πιο ελεύθερα. Πώς βλέπετε να διαμορφώνει την κατάσταση και τι έχετε να προτείνετε σε όσους μας ακούν για την αλλαγή αυτού του τρόπου αξιολόγησης, πρόσληψης των γιατρών στο Εθνικό Σύστημα Υγείας. Τώρα είναι η ώρα για αλλαγές. Μετά θα χάσουμε τον πουλί.
Καταρχάς, ευχαριστώ πάρα πολύ για την πρόσκληση. Φαντάζομαι ότι η πρόσκληση για όλους μας είναι να είμαστε λίγο προκλητικοί, να μην ρίξουμε τα πράγματα κάτω από το χαλί. Είμαστε και λίγοι εδώ, ξύλο πολύ δεν θα φάμε, άρα...
Μας παρακολουθούν άλλοι τόσοι και διαδικτυακά, να ξέρετε.
Από αυτούς δεν κινδυνεύουμε τόσο μεγάλο. Λοιπόν, καταρχάς, είναι να πω ότι είναι θετικό που η κυβέρνηση έβαλε ως πρωταρχικό θέμα την υγεία, μόνο μην ξεχνάμε ότι την είχαν βάλει και προηγούμενες κυβερνήσεις. Μπορεί όχι τόσο εμφατικά, αλλά την είχαν βάλει. Εκείνο που με φοβίζει, ενώ αυτό με ικανοποιεί, εκείνο που με φοβίζει είναι ότι οι πρώτες, πώς να το πω, τα πρώτα μηνύματα που έρχονται είναι ότι η προσπάθεια, προς το παρόν τουλάχιστον, φαντάζομαι ότι στο δρόμο, επειδή θα βρεθούν σε αδιέξοδα, είναι ότι προσπαθούν να βρεθούν λύσεις εντός του συγκεκριμένου παραδείγματος. Αυτό δεν γίνεται. Δηλαδή, εάν προσπαθήσουμε να βρούμε λύσεις, να καλυτερεύσουμε λίγο τους μισθούς, άκουγα και πριν τον Υφυπουργό και όλους να καλυτερέψουν τους μισθούς. Είναι καλά πράγματα αυτά, αλλά νομίζω ότι αυτά είναι μέσα στο υπάρχον πλαίσιο. Μέσα στο υπάρχον πλαίσιο δεν λύνεται το θέμα. Να πω επίσης ότι η Ελλάδα διαχρονικά είναι ένα απίστευτο παράδειγμα τελευταίου κομμουνιστικού κράτους και αρρύθμισης της αγοράς. Πώς ταιριάζουν αυτά τα πράγματα, κανένας δεν μπορεί να τα ξέρει. Τι σημαίνει αυτό? Το ξέρουμε όλοι μας ότι έχουμε ένα επί της ουσίας ιδιωτικοποιημένο σύστημα, όπου οι ιδιωτικές δαπάνες είναι στο Θεό, δεν υπάρχουν σε πολιτισμένα κράτη αυτό. Επίσης ξέρουμε ότι σε ό,τι αφορά τους γιατρούς, είμαστε σε ένα σύστημα διαβρωμένο, έχει μετρήσει ο σχολημένος ο Γιάννης Κυριόπουλος και πολλοί άλλοι επιστήμονες, ότι η παραοικονομία είναι τεράστια στον χώρο της υγείας, ενώ της δημόσιας υγείας. Μια παρένθεση εδώ, ότι αυτό που πάσχει, όχι τα ρίχνουμε όλα τώρα στο δημόσιο και το ιδιωτικό είναι μια χαρά, δεν είναι μια χαρά και ούτε το ιδιωτικό είναι μια χαρά. Έχουμε ένα σύστημα όπου οι γιατροί είμαστε η μόνη χώρα στον πολιτισμένο κόσμο που από τη στιγμή που ονομάζεσαι γιατρός και μάλιστα λίγο αργότερα που ονομάζεσαι και ειδικευμένος γιατρός, αυτό ισχύει μέχρι να πεθάνεις. Δηλαδή, ακόμα και αν ήσουν ο καλύτερος την ώρα που βγαίνεις, κανένας δεν ελέγχει τι γίνεται όταν πεθαίνεις, δηλαδή σε αυτή τη διαδρομή. Θεωρείς ότι είσαι γενικά άνθρωπος που μπορεί να παρέχει τις υπηρεσίες. Αυτό λοιπόν είναι ένα πρόβλημα το οποίο αν από εκεί δεν ξεκινήσουμε, όλα τα άλλα είναι θεωρητικά και να το αντιστρέψω, γιατί ακούω διάφορα πράγματα. Όταν εγώ προσλαμβάνομαι ως γιατρός, με τον τρόπο, το λάθος τρόπο που προσλαμβάνομαι, ακούσαμε πριν ότι στη Γερμανία είναι το κατεξοχή σύστημα το οποίο όταν κυνηγάμε εντός εισαγωγικών κάποιον, κυνηγάμε το διευθυντή, στον οποίο όμως έχουμε αναθέσει όλη την ευθύνη της οργάνωσης, ο οποίος όμως έχει επίσης την ευθύνη να απολογείται εάν αυτά που έχει κάνει έχουν αποτέλεσμα, εάν δεν έχουν. Εγώ ρωτάω τώρα, ότι αν εγώ όταν προσλήφθηκα, ας πούμε, στην Αγία Όλγα πριν πάρα πολλά χρόνια, για τι πράγμα προσλήφθηκα, να κάνω τι, να κάνω τι και πόσο από αυτό το τι. Δηλαδή, κανένας δεν μου είπε να κάνει ένα job description, δηλαδή, με άλλα λόγια να το πω και που λένε στο χωριό μου, ότι θέλω έναν χειρουργό, ο οποίος να είναι έτσι όπως πρέπει, με αυτά τα χαρακτηριστικά, με αυτά τα ποιοτικά χαρακτηριστικά και τον θέλω να μου κάνει αυτή τη δουλειά. Να μου βγάζει τόσα χειρουργία, να μου ρίξει τους δείκτες αναμονής, δηλαδή κάτι που να ξέρει, ή μάλλον να ξέρει ο μάνατζερ που θα με κρίνει, που θα λογοδοτήσω, εάν απέναντι σε αυτά τα κριτήρια με τα οποία προσλήφθηκα, έχω αποδώσει ή όχι. Υπάρχει αυτό? Κανένας. Προσλαμβάνουμε χειρουργούς γενικώς. Και το χειρότερο ότι προσλαμβάνουμε χειρουργούς γενικώς για τον Ευαγγελισμό και για το νοσοκομείο των Γιαννιτσών. Δεν έχω τίποτα με τα Γιάννητσα. Απλώς λέω ότι είναι μια να πω το Βόλο που είναι η πόλη.
Από εκεί κατάγεται και ο νέος υπουργός, οπότε...
Ωραία. Σωστά. Το ξεχάσαμε. Λοιπόν, θέλω να πω λοιπόν ότι πρώτον, ασυμμετρία στα κριτήρια, μη ύπαρξη συμβολέου με το οποίο προσλαμβάνουμε. Και πάμε τώρα και σε αυτή την περίφημη πλήρη και αποκλειστική απασχόληση. Επειδή ήμουνα στην Επιτροπή του Αυγερινού όταν στείναμε το Εθνικό Σύστημα Υγείας, τότε είχε μια λογική αυτό. Έτσι. Ο Αυγερινός στην εισηγητική του έκθεση είπε ότι ό,τι ρυθμίζουμε σήμερα, εάν δεν τα ελέγξουμε σε 5-6 χρόνια, να δούμε τι έχει αποδώσει και να τα αλλάξουμε, το σύστημα θα καταρρεύσει. Λοιπόν, κατέρευσε. Γιατί δεν κάναμε αυτό? Άρα λοιπόν η πλήρης και αποκλειστική απασχόληση εκείνη την εποχή είχε δίκιο. Εκείνο το οποίο σήμερα, ύστερα από 40 χρόνια, είναι και παραπάνω, έχουν περάσει ήδη 40 χρόνια, λέμε τα ίδια πράγματα. Και θεωρούμε ότι η αποκλειστική απασχόληση είναι στοιχείο που να χαρακτηρίσει ένα σύστημα με δημόσια κατεύθυνση ή με ιδιωτική κατεύθυνση ή οτιδήποτε. Δηλαδή, ποιον νοιάζει, είναι κανένας άρρωστος στον κόσμο, ο οποίος όταν πάει στο νοσοκομείο και βλέπει τον γιατρό του, το ρωτάει, εσείς με τι καθεστώς είστε πλήρως και αποκλειστικής απασχόλησης? Τι τον νοιάζει με τι είμαι εγώ? Τον νοιάζει ότι πρέπει εγώ που είμαι εκεί, εξ ονόματος του συστήματος, ο οποίος πρέπει να τον εξυπηρετήσει, να κάνει τη δουλειά του. Δηλαδή να ξέρει να κάνει τη δουλειά του και με βάση αυτό να ελεγχθεί. Άρα λοιπόν είναι μια φαινάκια. Άκουσα πολλούς ακόμα και αγαπημένους μου αρχηγούς κομμάτων να λένε ότι η ανέρεση του γιατρού πλήρους και αποκλειστικής απασχόλησης είναι ένδειξη, να μην πω απόδειξη, πλήρους ασυδοσίας και ιδιωτικοποίησης του συστήματος. Θα αστειευόμαστε. Δεν έχει καμία σχέση με αυτό το πράγμα. Μπορεί να έχεις μια χαρά ιδιωτικοποιημένο σύστημα και νέους γιατρούς πλήρους και αποκλειστικής απασχόλησης και να έχεις και μια χαρά ιδιωτικό σύστημα που να έχεις πλήρη και αποκλειστική απασχόληση. Άρα αυτό είναι ένα πράγμα που δεν δουλεύει. Δεν δουλεύει διότι όλοι οι γιατροί δεν είναι ίσοι και εδώ είναι η ευθύνη, δυστυχώς έφυγε ο πρόεδρος του Ιατρικού Συλλόγου Θεσσαλονίκης. Υπεύθυνα τα συνδικάτα, οι γιατροί είναι υπεύθυνοι γι' αυτό. Όλοι οι γιατροί δεν κάνουν την ίδια δουλειά. Πουθενά στον κόσμο δεν κάνουν την ίδια δουλειά. Τα συμβόλαια των γιατρών σε όλο τον κόσμο είναι, θα με συγχωρέσετε που θα το πω, αλλά σαν τα συμβόλαια, όχι τόσο ψηλά, ενώ σε μισθούς, αλλά από τη φύση τους, σαν τα συμβόλαια των ποδοσφαιριστών. Εντάξει, δεν παίρνει τα ίδια λεφτά ο Μέση με τον συμπαίκτη του δίπλα.
Και αναειδικότητα υπάρχει διαφορά.
Αυτό λέω. Άρα υπάρχει θέμα διαφοροποίησης, ειδικοτήτων, δουλειάς συγκεκριμένης. Το τι άκουσα πριν για τα DRGs, το τι φέρνεις στο νοσοκομείο. Εάν εγώ φέρνω εκατομμύρια στο νοσοκομείο, δεν μπορώ να πληρώνω, να αμείβομαι το ίδιο με κάποιον που δεν φέρνει. Έτσι, αυτό εκ των πραγμάτων. Διότι, άρα λοιπόν, για να μην μακρηγορούμε, μια περιγραφή, όταν θέλουμε να μιλήσουμε για σεξουαλικές σχέσεις, πρέπει να ξεκινήσουμε από την περιγραφή του τι θέλει το νοσοκομείο, το σύστημα, από τον κάθε γιατρό.
Μπράβο, άρα τώρα τι γιατρό του εσύ
δηλαδή,
θα θέλαμε.
Θα θέλαμε ένα γιατρό του εσύ πρώτον, ο οποίος να περιγράφει τη δουλειά του, επιμένω σε αυτό, να ελέγχεται αν αυτό που κάνει είναι σύμφωνο με το συμβόλαιο που έχει υπογράψει, να διαφοροποιούνται οι αμοιβές με βάση το νοσοκομείο, έτσι, το μέγεθος του νοσοκομείου, το τμήμα, το αποτέλεσμα και όλα αυτά τα πράγματα. Υπάρχουν και επίσης τώρα παρένθεση. Γιατί αγαπάμε τόσο πολύ την παρθενογέννηση σε αυτή τη χώρα? Δηλαδή νομίζουμε ότι όλα θα τα ανακαλύψουμε εμείς εδώ. Μα έχουν ανακαλυφθεί. Αυτοί οι αλγόριθμοι που τώρα χρησιμοποιεί το Facebook ή όλα αυτά τα συστήματα για να έρχονται, υπάρχουν αλγόριθμοι σε όλο τον κόσμο που καθορίζουν τις αμοιβές, που έχουν σχέση με το κλινικό έργο, με το ερευνητικό έργο, με τις δημοσιεύσεις, με το εκπαιδευτικό έργο. Δηλαδή, με έχουν εκεί εμένα ένα γιατρό να εκπαιδεύω τους καινούριους γιατρούς και κανένας δεν με αξιολογεί και κανένας δεν με πληρώνει, οι αμοιβές μου δεν σχετίζονται με το τι κάνω στην εκπαίδευση. Άρα λοιπόν, ας πάρουμε αυτούς τους αλγορίθμους, να τους προσαρμόσουμε και αμέσως θα έχουμε τις αμοιβές των γιατρών, οι οποίες δεν θα είναι και εις βάρος του συστήματος, διότι αυτοί που θα αμείβονται παραπάνω θα έχουν φέρει περισσότερα λεφτά στο σύστημα και αυτοί που θα αμείβονται λιγότερο θα αμείβονται γιατί δεν εκπαιδεύουν, γιατί δεν το ένα, δεν το άλλο, μέχρι να τελειώνει.
Σε αυτό που λέμε πλήρη και αποκλειστική, πώς θα έβλεπες την εργασιακή σχέση ενός γιατρού, δηλαδή να έχει δικαίωμα να χειρουργεί και εκτός?
Όπου θέλει, στο Θεό, αρκεί να κάνει το συμβόλαιο που έχει. Τι με νοιάζει εμένα, το συμβόλαιο που έχει, εάν εγώ λέω στην Αγγλία, τι τους λες, έχεις 6 sessions χειρουργικά τη βδομάδα και πρέπει να βγάζεις αυτό ανάλογα με την ειδικότητα, έτσι, και ανάλογα με το τι είναι. Άλλο είναι ο καρδιοχειρουργός, αλλά έχεις ένα πρόβλημα. Εάν μου το κάνεις αυτό, τι με νοιάζει εμένα τι κάνεις μετά? Εγώ θέλω αυτό.
Τώρα, θα μπορούσε...
Άρα, γιατί δεν ξεκινάμε από εκεί?
Ωραία. Τώρα, πρόσφατα η προηγούμενη κυβέρνηση, που είναι συνέχεια, η σημερινή είναι η συνέχεια της προηγούμενης, πέρασε μια διάταξη που έδινε δυνατότητα στους γιατρούς του ΕΣΥ, λέει, να χειρουργούν και στον ιδιωτικό τομέα. Δεν θα μπορούσαν να χειρουργήσουν ιδιωτικά μες στο νοσοκομείο?
Την έχει. Ας γίνει και στο νοσοκομείο, δεν έχω καμία αντίρρηση. Εάν μπορεί στο συμβόλαιο να λέει ότι θα κάνεις αυτά, έτσι, αυτά και μετά, εάν το νοσοκομείο έχει υποδομές, μπορεί να κάνεις και το άλλο.
In Germany, for example, as we all know, private hospitals are not that populated. In Holland, there is no private hospital. But if I want to be operated on, I will hire him. By insist, it's very critical. The system should know what it demands from each doctor, and from the moment it does that, it's okay. So I say, what is the mistake of the previous regulation? Well, it does properly what it does. If the system can invite people to do a specific job at the clinic for the people who don't have to go to the private sector, I need to do that. This is the right system, but doctors should be remunerated based on that. The previous mistake is that we have a requirement, 3 here, 3 there, etc. No, I insist for years, may have a job description to know what exactly you demand from me. Mrs. Economopoulou, I've read a recent article of yours, and you should say that the personnel should be given different forms of professional relations. That should go for doctors alone or the rest. Allow me to start with a remark. Whatever you pay, you get. Whatever you design, you will have respective results. Freelancing historically is known that was the main choice of the medical community. A lot of our colleagues, nurses, X-ray experts, IT, dietologists, also are hired in the private sector, not obviously some of them. Majority chooses freelancing instead of exclusive employment. And exclusiveness has to do with specialties that cannot be occupied or not be hired by the private sector. In a single salary list, this is an obsolete system of communist inspire that seeks new persons but does not promote performance. Both. To give you some example, Mr. Dervenis has said the same. It is irrational to pay the same Dr. A, B with a microbiologist. It is irrational at the same time to pay the same any specialty in the hospital that chooses to work in Athens and the same salary in a regional hospital. Nursing is a very difficult profession, other difficult condition that is we are lagging behind. Lack of nurses leads to huge deficits in healthcare. We have a lot of people every day, every year graduating, nurses graduating, but they choose to do something else. So it's not fair to pay the same people that produce work and those who do not. The conditions are different. So this discussion should take place at a region level. Is it something that could operate in Greece? Well, if we need to have the assessment of Now we need to have fit for purpose in order to cover the needs. So if we open this Pandora box, won't we have any reactions from trade unions? Of course. First of all resistance should be overcome because there is perceptions, and we can overcome all these perceptions if there is a strategic planning. Secretary General, Mr. Georgiadis. Those departments with high technology bring higher yields. In the afternoon sessions of hospitals, for example, we see that in the they get an extra bonus when they work. Well, it operates. Can't we introduce that for the rest of the personnel? Yes, it is the only step forward. For example, I am allowed to get some money, but there is a ceiling up to what I can get. With 10 patients in the afternoon, I have completed here 1,000 euros a month. So why should I get 11 patients? That doesn't work properly because that could give another sprint, not for then. Therapies, treatments, it operates after 7 years. A colleague in Savas was judged right and got his money from a 24-hour operation of the hospital. There are widows in the legislation. In your sector, we see that a lot of colleagues actually quit. It has to do with the working hours with the colleagues. Well, it has to do with the salary, university. A degree with 800 euros. Why should I stay here whereas I can get 8,000 working abroad by giving more money to private sectors? By giving money from the private sector, the public sector is deprived of personnel. If we analyze that and focus on salaries alone, we will see that we won't have any results. The whole attitude has changed, but we are lagging behind. The government says that it will modernize equipment in hospitals, etc. Well, but equipment cannot work when we have people leaving the hospital.
There's another issue regarding the islands. We can, through telemedicine, we can see diagnostics or MRIs, for example, or scans online and provide our opinion. These are these are decisions that cannot be overcome. So when we function, we are exposed by the state. So either we should have all specialties on all health centers, on all islands, or they should change the legislation. But it's not also only money. Also, the structure plays an important role. Sometimes this structure is very problematic. For example, the heads of units have to be evaluated, which they are not. So we need to see how we can change the framework. The organizations do not have positions according to the criteria that the law sets. For example, when the universities change their status, we do not have correspondence in the criteria set in the hospitals for hires. The organizations are based on obsolete models. Sometimes we have clinics that are not used. Independence is very important in the hospitals. In 1983, we had Alexander the Great on the wall of the hospital. So it is very important to have structures that are welcoming the new specialties. Organograms are very important in every enterprise, in every business. So here in the organization, we also need to have a functioning organization.
Αλλά εδώ
The managers of the organizations of the hospitals know exactly what are the best solutions for the hospitals. So each manager knows what are the vacancies and the needs. So we need to cooperate with. The government needs to cooperate with them. The personnel, the administrative staff, etc. of a hospital have to be in concert with the needs. Unfortunately, in hospitals, there is lack of confidence. There is skepticism. And that's our experience from former reforms. Also in hospitals, 70% of vacancies are filled in by auxiliary personnel. We always speak about vacancies. This creates important problems. Both in terms of pensions, retirements, rather, and the halts to hires due to the memoranda created a gap that has not yet been filled. The auxiliary personnel, and I hope that they would become permanent soon. Under the current circumstances, do not have any motive. Because they are not evaluated based on their performance. This motto of the syndicates against the private structures of hospitals is something that holds us back. Yesterday, the government announced increases in salaries. They spoke about 70 euros per month. Actually, which is this is 46 euros after withheld amounts. In high rank positions, We cannot have vacancies, otherwise we will not have a flexible and functioning organization. On the other hand, we need to evaluate our personnel. We didn't have evaluation since 2004. So for more than 15 years, we haven't had evaluations for high-rank administrative executives. I would like to thank you all for this discussion. I believe that the matters will be dealt with and the reform will take place. Thank you, everyone.
Για περισσότερο από έναν αιώνα βρισκόμαστε στην πρώτη γραμμή της έρευνας, ανακαλύπτοντας φάρμακα, εμβόλια και καινοτόμες λύσεις υγείας που κάνουν τη διαφορά στη ζωή εκατομμυρίων ανθρώπων. Ακούμε τις ανάγκες των ασθενών και λειτουργούμε υπεύθυνα ώστε να διασφαλίζουμε πως οι θεραπείες μας είναι προσβάσιμες σε όσους τις χρειάζονται. Δεσμευόμαστε ότι θα συνεχίσουμε να εργαζόμαστε για ένα υγιέστερο, φωτεινότερο μέλλον για όλους. MSD. Inventing for Life.
The way we see it, the impossible
is not impossible.
The impossible is simply what hasn't been achieved yet.
So we pursue it.
We chase it down.
We tackle it for answers.
We surround it for a way in. This is how every once impossible breakthrough has ever been created.
A revolutionary approach to cancer therapy.
A path to a cure for HIV.
A cure for hepatitis C.
A better, healthier world for every person to live in.
None of this is impossible now because of the people you work with.
The communities we stand with.
And the partners we push forward with.
Together, we've created what's possible through science,
Grit.
Compassion.
And courage.
And we will do it again.
No matter what.
No matter the stakes.
No matter who says we can't.
When faced with the impossible, we don't falter.
We band together, and we prove it wrong.
The impossible
is not impossible.
It's what's next.
C'est notre futur.
우리가 다음에 해야 할 일입니다.
قدم بعدیه.
ano ang susunod.
Es lo que sigue.
呢個就係我哋嘅下一步。
It's what's next.
Tomorrow is a promise, the promise of a new future, of successes earned, as we promise our customers to help them drive healthcare forward. Our customers are inspiring us to reimagine how healthcare should work, where human ingenuity can finally unleash the power of ever-expanding health information, analytics, and technology. Where clinical trials are designed around the patient, where predictive analytics prevent medical errors before they happen, where all healthcare players work together to make patients' lives better, where every medical decision is informed by evidence, where treatment costs reflect the value they bring, where precision medicines seamlessly find their way to the right patient. It's the promise delivered by mobilizing unparalleled data, analytics, technology, and expertise, connecting stakeholders to improve health around the world. The promise rooted firmly in data science and domain expertise, the promise of the future.
At Janssen, we are called to rise each morning and achieve today what last night seemed unimaginable. We are called to blaze paths where others fear to go, to unravel and repair the very code of life, to treat, intercept, prevent, and cure. We are called to open our doors to collaboration and our arms to the needs of each patient, so that what works in our labs also works in their lives. We are called to advance how medicines are made and made accessible around the world. We are Janssen, the pharmaceutical companies of Johnson & Johnson, and we are heeding the call. Bravely and boldly, fighting sickness with science, improving access with ingenuity, and healing hopelessness with heart, until the world's most daunting diseases are found only in the pages of history books. At Janssen, we're creating a future where disease is a thing of the past.
Every crisis provides the opportunity for a breakthrough. In 1849, we made our first breakthrough, an inventive and groundbreaking way to treat parasites. We discovered how to get life-saving supplies to the Union Army. We broke through the barriers of mass production, making penicillin and other antibiotics accessible on a massive scale.
The life-preserving drugs known as antibiotics met the challenges of war.
And contributing to one of the biggest life-saving measures of the 20th century.
We're entering a new era of medicine in which the natural lifespan may be greatly expanded.
We fought polio with an oral vaccine, so millions of children could be children again. We innovated a needle that would be one of the key tools in eradicating smallpox.
The disease has been wiped off the face of the earth.
We took on some of the greatest causes of pain, illness, and early death and fought them with treatments that improved the quality of our hearts, bodies, and even helped the way we love. We harnessed cutting-edge science to create breakthrough therapies that help people with cancer live longer. And now, we have broken through the biggest health crisis of our time. Over 170 years of breakthroughs, and we're just getting started.
You've always been told you have potential. But it's not enough to just have it. You need to feel it. It takes time, sweat, and tears. Some wins. Big wins. It takes a we never settle attitude. It takes work, teamwork, hard work. Repeat, repeat, and repeat. To be shaken, to be awakened, to test your limits. Overcome your fear of failure. It's a step closer to success. Look closely at the possibilities. Keep pushing your mind and body. Whether you're on the tracks, in the labs, or in midair, find your potential. Ignite it.
All over the world, people are waiting for innovative medicines for the treatment of diseases with unmet medical needs. At Astellas, we are united in a common purpose. We will continue to provide innovative pharmaceutical products that address unmet medical needs in order to deliver a better tomorrow for patients.
To contribute toward improving the health of people around the world through the provision of innovative and reliable pharmaceutical products. This is our raison d'être. This is why we exist. To continuously contribute to the needs of society, we must look 10 or more than 20 years in the future and never stop pursuing innovation in everything we do. We'll generate innovation by treating external environmental changes as opportunities to bring value to patients around the world. Our vision is clear. Astellas stands on the forefront of healthcare change, turning innovative science into value for patients. We are changing tomorrow.
The EU is falling behind other regions of the world in getting new treatments to patients, securing R&D investment, and attracting talent. It takes 426 days to approve a new active substance in Europe, compared to 244 days in the US. Expedited pathways exist to accelerate approval of promising treatments, but Europe is not realizing their potential. In 2021, the European Medicines Agency used expedited pathways for just 9% of new active substances. In the US, that figure was 71%. This means slower access to new medicines for European patients. Europe's share of global clinical trials is also in decline. Compared with an average of 25.6% over the last 10 years, Europe accounted for only 19.3% of global clinical trials in 2020. This means that patients in Europe are not able to take part in groundbreaking research being carried out elsewhere. The situation is most acute for the therapies of the future, CAR-T and advanced therapies medicinal products. Since 2020, CAR-T trials have almost tripled, but only 2 in 10 clinical trials happen in Europe. And during the past decade, Europe consistently hosted the lowest number of ATMP clinical trials compared to the US and China. Aware of the importance of the regulatory framework for its competitiveness, China has hired 1,000 people in 2022 to increase their regulatory workforce. To attract greater research investments and clinical trials in Europe, our regulatory system needs greater capacity, agility, and to be more streamlined. We have put together the regulatory road to innovation, a 12-point action plan to do just this. Don't let Europe fall further behind. Back innovation in the EU pharma legislation.
Για περισσότερο από έναν αιώνα βρισκόμαστε στην πρώτη γραμμή της έρευνας, ανακαλύπτοντας φάρμακα, εμβόλια και καινοτόμες λύσεις υγείας που κάνουν τη διαφορά στη ζωή εκατομμυρίων ανθρώπων. Ακούμε τις ανάγκες των ασθενών και λειτουργούμε υπεύθυνα ώστε να διασφαλίζουμε πως οι θεραπείες μας είναι προσβάσιμες σε όσους τις χρειάζονται. Δεσμευόμαστε ότι θα συνεχίσουμε να εργαζόμαστε για ένα υγιέστερο, φωτεινότερο μέλλον για όλους. MSD. Inventing for Life.
The way we see it, the impossible
is not impossible.
The impossible is simply what hasn't been achieved yet.
So we pursue it.
We chase it down.
We tackle it for answers.
We surround it for a way in.
This is how every once impossible breakthrough has ever been created.
A revolutionary approach to cancer therapy.
A path to a cure for HIV.
A cure for hepatitis C.
A better, healthier world for every person to live in.
None of this is impossible now because of the people you work with.
The communities we stand with.
And the partners we push forward with.
Together, we've created what's possible through science,
Grit.
Compassion.
And courage.
And we will do it again.
No matter what.
No matter the stakes.
No matter who says we can't.
When faced with the impossible, we don't falter.
We band together, and we prove it wrong.
The impossible
is not impossible.
It's what's next.
C'est notre futur.
우리가 다음에 해야 할 일입니다.
قدم بعدیه.
ano ang susunod.
Es lo que sigue.
呢個就係我哋嘅下一步。
It's what's next.
Tomorrow is a promise, the promise of a new future, of successes earned, as we promise our customers to help them drive healthcare forward. Our customers are inspiring us to reimagine how healthcare should work, where human ingenuity can finally unleash the power of ever-expanding health information, analytics, and technology. Where clinical trials are designed around the patient, where predictive analytics prevent medical errors before they happen, where all healthcare players work together to make patients' lives better, where every medical decision is informed by evidence, where treatment costs reflect the value they bring, where precision medicines seamlessly find their way to the right patient. It's the promise delivered by mobilizing unparalleled data, analytics, technology, and expertise, connecting stakeholders to improve health around the world. The promise rooted firmly in data science and domain expertise, the promise of the future.
At Janssen, we are called to rise each morning and achieve today what last night seemed unimaginable. We are called to blaze paths where others fear to go, to unravel and repair the very code of life, to treat, intercept, prevent, and cure. We are called to open our doors to collaboration and our arms to the needs of each patient, so that what works in our labs also works in their lives. We are called to advance how medicines are made and made accessible around the world. We are Janssen, the pharmaceutical companies of Johnson & Johnson, and we are heeding the call. Bravely and boldly, fighting sickness with science, improving access with ingenuity, and healing hopelessness with heart, until the world's most daunting diseases are found only in the pages of history books. At Janssen, we're creating a future where disease is a thing of the past.
Every crisis provides the opportunity for a breakthrough. In 1849, we made our first breakthrough, an inventive and groundbreaking way to treat parasites. We discovered how to get life-saving supplies to the Union Army. We broke through the barriers of mass production, making penicillin and other antibiotics accessible on a massive scale.
The life-preserving drugs known as antibiotics met the challenges of war.
And contributing to one of the biggest life-saving measures of the 20th century.
We're entering a new era of medicine in which the natural lifespan may be greatly expanded.
We fought polio with an oral vaccine, so millions of children could be children again. We innovated a needle that would be one of the key tools in eradicating smallpox.
The disease has been wiped off the face of the earth.
We took on some of the greatest causes of pain, illness, and early death and fought them with treatments that improved the quality of our hearts, bodies, and even helped the way we love. We harnessed cutting-edge science to create breakthrough therapies that help people with cancer live longer. And now, we have broken through the biggest health crisis of our time. Over 170 years of breakthroughs, and we're just getting started.
You've always been told you have potential. But it's not enough to just have it. You need to feel it. It takes time, sweat, and tears. Some wins. Big wins. It takes a we never settle attitude. It takes work, teamwork, hard work. Repeat. Repeat. And repeat. To be shaken, to be awakened, to test your limits. Overcome your fear of failure. It's a step closer to success. Look closely at the possibilities. Keep pushing your mind and body. Whether you're on the tracks, in the labs, or in midair, find your potential. Ignite it.
all over the world, people are waiting for innovative medicines for the treatment of diseases with unmet medical needs. At Astellas, we are united in a common purpose. We will continue to provide innovative pharmaceutical products that address unmet medical needs in order to deliver a better tomorrow for patients.
To contribute toward improving the health of people around the world through the provision of innovative and reliable pharmaceutical products. This is our raison d'etre. This is why we exist. To continuously contribute to the needs of society, we must look 10 or more than 20 years in the future and never stop pursuing innovation in everything we do. We'll generate innovation by treating external environmental changes as opportunities to bring value to patients around the world. Our vision is clear. Astellas stands on the forefront of healthcare change, turning innovative science into value for patients. We are changing tomorrow.
The EU is falling behind other regions of the world in getting new treatments to patients, securing R&D investment, and attracting talent. It takes 426 days to approve a new active substance in Europe, compared to 244 days in the US. Expedited pathways exist to accelerate approval of promising treatments, but Europe is not realizing their potential. In 2021, the European Medicines Agency used expedited pathways for just 9% of new active substances. In the US, that figure was 71%. This means slower access to new medicines for European patients. Europe's share of global clinical trials is also in decline. Compared with an average of 25.6% over the last 10 years, Europe accounted for only 19.3%.
Κυρίες και κύριοι, αν θέλετε καθίστε για να ξεκινήσουμε την τέταρτη ενότητα του φετινού συνεδρίου. Ο τίτλος είναι «Πρόληψη και πρωτοβάθμια φροντίδα υγείας». Έχουμε τη χαρά και την τιμή να έχουμε κοντά μας και θα την καλέσω στο βήμα την νέα αναπληρώτρια.
We have with us the Deputy Minister Irini Agapidaki. You have the floor for 10 minutes. Good afternoon, everyone. I'm very happy that I have the opportunity to start my office in a ministry which combines two very critical issues, primary care and public health. And we have the opportunity to speak about these matters in detail. Despite the fact that we are in a conference of specialists and experts, I'm not sure that everyone understands the concepts in the same way. Many times, both in the public sector and in the academic sector, we speak about public health and we mean the structures of the state. Public health is something different. It's an independent health science sector, protection, promotion, prevention, and we are speaking about population. So we are outside the medical model that we see in the one-to-one medical model, doctor-patient, but we focus on groups of populations or the whole population. As regards the general chronic care model and other models that regard the management of chronic illnesses or their prevention in the community, these are an indispensable, integral part of the prevention. Unfortunately, all these years in our country, we have misunderstood some concepts. Usually, we speak about primary care, but we don't speak about the model of primary care that we want, how we will build it, how we will be able to have a sustainable model, what this means for the health system, and what it means for the population's health. Just because we had the GPs that were introduced in the previous government, and for the first year we have good results in this sector. Unfortunately, again, here we stop the discussion at the level of GP. However, primary care has more elements than the GP in it. The model that we want to implement in the country, and allow me here to say something personal, I always feel that continuation is an important element in everything that we do. Before me, there were other ministers, and I have to learn from them. So I found out that in the bibliography of Yorgos Genimatas, it mentions, also I found this in the collective volume of the Conference on Public Health after Eleftherios Venizelos. In 1994, the country invited an experts committee that said, in order to have a strong national health system, we need an integrated, sustainable system of primary care. It was in 1994, before the crisis, which has to be implemented for 10 years so that we can see results. This is what we are invited to do now. We are not reinventing the wheel here, but in practice we have to learn from the mistakes of the past. And I need to tell you that I'm not speaking about an academic, but as a politician here. So for me, the responsibility to solve a problem lies with the one who understands the problem, not with the one who has created the problem. They can be liable for this, but only the party that can understand the pathology of a problem can resolve it. So that lies with the government now. We have municipal practices, regional practices, the health centers, various units here and there in the primary care, which are not connected to each other. They are not creating a cohesive and integral part, which is understood by the content. For example, the citizen has to call the GP. If the GP doesn't answer, then they do not know where to go in order to cover their need. So we have to travel the journey from A to B. In this model, the integrated model of prevention is the one that we will adopt. You see, in the first level, we have the minimum cooperation. This happens sometimes in our country, and it is closely related to the multidisciplinary practice and interdisciplinary practice. In other words, the group of health professionals providing care, because care is provided by a group of people, not one person, they have to know what everybody is doing. And they have to understand which is their contribution in the therapeutic result. For example, the doctor has to understand that the nurse contributes to the medical result and be able to act on an interdisciplinary level and vice versa. So integration, we also want integration in administrative levels as well. From level A, which is the minimum that one can achieve, minimum cooperation, a basic cooperation in between remote structures. For example, the mental health center with the health center or the local doctor have to talk with each other. Another basic element is the co-located system in the same structure to have different types of services. That's what we're going to implement. Already we have started working on this. For example, I have a family that has financial problems, and the children have body health problems. And the mother and the child come to the health center, or they go to the GP. Is anyone here to screen this family and see what are their social needs? No. Does this create problems in promoting their health? Of course. Is there anyone who will treat their mental health issues? No. So we have to integrate the primary care services, which are now fragmented, into a cohesive network, so the citizens can understand what is a health center, what's the role of the GP, where we go for every different thing. Also, we need a strong central administration and decentralized function. I want to be brief, so I won't show you all my slides. Let me only focus on these sector indicators. I have worked in the health sector for many years. We have made a lot of proposals to the ministry in the past so that to have the tools to measure the impact on the population. If this is done by just one person, then this person is going to be burned out. So we need to work with each other. Now we have the tools, we have the funds from the RRF, and we have the knowledge. A reference study for the Commission that we use in Europe so that we understand how the health impacts on the community is related to the structure of the primary care is shown here. You see that based on certain primary care indicators, the systems are classified as weak, medium, and strong. We are weak in Greece in primary care, as most European countries. This model is some years ago, but things haven't changed since then. And you see here a correlation in between primary care impact and better health of the community. So if we have the primary care well established, well functioning, and well integrated, and if you also have good understanding within the population, you can have better population health. If we didn't have the programs of mammographies, for example, if I go to the GP, they would say you have to get your mammography earlier than other women, and you have to repeat it every 6 months. That's good for me, but is the population indicators change? No. That's why we want these programs, because the indicators change. At the same time, we have to still focus on the personalized approach. That's why we want primary care. Another important thing, in my opinion, and I'm very sorry that I can see it again and again in the public discussion. Mr. Negis has written about this, many health journalists, the problems in the various fragmented units. Even after the pandemic, we have dealt with COVID so much that we have forgotten that we need to take care about that structure. So now we don't have a navigator for health services. That's what we want to do. We have a plan. Indicatively, these are the actions per pillar that we are going to implement. It's the first time that the country invests more than 600 millions in prevention. I will stop here, but because we'll have time during the panel. Thank you. Now let me ask the speakers for our next panel. Mr. Evangelos Fragoulis, Secretary of Family Medicine Association, Mr. Fragoulis, Mr. Amariolis of the Areopolis Health Center, and Mr. Pirokio from GSK, along with the Minister.
Yes, Antonino, there. Okay. Συνδεθήκαμε λοιπόν και με την Αρεόπολη της Μάνης. Βλέπουμε τον κύριο Ανάργυρο Μαριόλη. Να ξεκινήσω λίγο...
Let me start with our discussion with Mr. Mariolis, because he's our remote speaker, and as we heard, the government wishes to enhance, to support primary care. You are a doctor, you are a director of a health center at a remote area. Which are the basic axes to focus on in order to support you? Thank you very much, Mr. Negis, for the invitation. Good afternoon, everyone, and congratulations for to the minister for her presentation, because she spoke about what we dream of for years. In 2 words, I would say that we should leap forward. We have an opportunity, we need to seize it. You know very well that health services, especially in the primary care, in their classical form, are under pressure. The minister passed on several messages regarding the change of the demographics in the models of illnesses, the models of patients. All these pressures make us need structural changes in terms of performance and in terms of cost efficiency. At this moment, we have know-how regarding the services that we can offer. For the first time, in Greece, we introduced the GP, which is now just starting. This general practitioner introduction is very important. And as Mr. Agapitaki mentioned, the GP is not the only element in primary care. I believe that we have a lot to do in the future, so the citizens have to understand what we can offer them. Use of services in Greece is closely connected to the choice of the end users. So the value of the health services is determined by the user's decisions. We saw a vaccinations program that during the pandemic that was very successful. Now we have another program to deploy, the general practitioner, who will be your guide in your health journey. So through this whole process, we need to see which are the uncovered needs. I do agree with Mr. Agapitaki that we have to focus on the general population and the vulnerable groups. You mentioned networks in the primary network. Which will be the nodes in this network and the purpose? These are the smart investments to do. How can we ensure a strong and capable health professionals? In the past, we had some disadvantages. The reform was very weak. We didn't have enough people. We had political immaturity. We didn't have public consultation. We didn't have consensus mechanisms. We didn't have technocratic support. So I think that all the aforementioned have been now resolved. So we can proceed to create networks, because We don't want a fragmented administrative practice, but we want an integrated whole. I think that today we have advanced, and I believe that we can progress to horizontal actions and cooperations. For the moment, we have a fragmented number of units. We have, for example, 300 health centers, we have the regional centers, we have local or municipal practices, we have private practices, social practices. If we want a strong primary care, that will be an efficient defense, we need the full digitization of transactions and integration of all structures. The role of the health centers via the networks, that will be the coordinator. This will be decisive as regards the private practices as well. We have to ask ourselves, do we want a small, weak, fragmented system of many primary units, or do we want a centralized, well-funded, cohesive, and pluralistic public, social, and private health sector? We can have good technology now. We can integrate these structures at the level of electronic file. But we have to proceed, and I know that the minister knows that, to the training of the personnel, which hasn't started yet, in order to aim at a change of mentality, a change of culture, in order to promote the public health concept. Primary care is not identical to the GP. We want to have a package of services, because each person, each specialty has different types of services to offer. I finish with the distortions that we have today, which are the obstacles in the health sector. We focus on expensive technology without an integrated and interdisciplinary approach. We do not interconnect the services in the primary care. Who sees vulnerable groups today? Who exercises prevention of symptoms? And of course, access is another major issue that has to be resolved via networks of primary care in cooperation with private practices, with private doctors. So we have to see funding and incentives. Thank you very much for your intervention. As I understand, after Mr. Mariolis, we have many services, but we do not have the backbone so that the services can be connected with each other and operate as a whole. We have various services at the primary level, but everyone does whatever they think is better. But I do not know whether there is any national guidance. Certainly, that's why I said before that we have to create a system that is easily understood. I have worked in a mental health sector. We had a similar problem. A lot of different services with different missions. You know, the ministry has to design, oversee the implementation, and control deployment. For years, we are accustomed to believe that primary care or the health center is like an extension of a hospital. And we say, okay, let's go to the health center, and if I don't find anyone there, I'll go to the hospital. No, that's not what we want. Healthcare is something different. Second problem, we spend too much money because the problem is not financial. The problem is of strategic planning. We have to see which is the job of the health center. It's not an extension of the hospital. You have to explain the pathway, the journey of the citizen within the health system. We need to explain who is going to be the navigator to guide them. We have to give. Let me give you one example from the many programs that we have integrated under the RRF. For example, we are modernizing LD because we want to be ready for any next pandemic. So epidemiologic oversight is necessary. The personnel have to be trained how to use the tools. If you give me a screwdriver and you tell me just fix the lights, I will not be able to do those. So I will be electrocuted. I have to be trained. So we need to train the people. Also, we want to see which are the vacancies. We do not have field epidemiologists in Greece. We have to find them. Many professions we lack, and we have to find them. Moreover, Public Health Menaces, Public Health Threat Prevention Center. By utilizing technology, we will trace meningitis, for example, at an area, and intervene at the source with specific teams who will do exactly this controlling so that we don't have expansion to the general population. So we need to have a central design from within the ministry along with the strategy. We need the oversight over the implementation and also decentralized operational functionality. That's how we are going to deal with the primary care. We are liable against the taxpayers. All these services have a cost. So we speak about the paradigm shift. Of course, and I'm very clear about this. Okay, so we need to communicate this to the people. Exactly. We would like to 1 day or 2 days to speak about the reforms that we have planned. For example, health consultants. What is this, says the journalist. This will be the navigator to give us information in a reliable manner. This person will be, this is not going to be a person, but an application on our mobile phone based on our personal medical file. They can scan the data and they would say, for example, you are obese. You know, in your neighborhood, there is this health center having this specific specialty. You can visit them and they can guide you. Or you have to do your mammography because you are in a 6 months iteration model. So actually, it's a digital assistant. It's a digital health counselor. It complements the services of the GPs. Of course, we cannot substitute the GPs with the application. And this assistant will make people understand what they should focus on. Now, Mr. Birocchio, I would like to congratulate you. You're the CEO of GSK in Greece. I congratulate you that you are in a discussion not about clawbacks, but about prevention. Of course, your company deals with vaccines. So please please tell us, what's the role of vaccination in prevention, and how, as Greece, as a country, we can prevent progress with vaccinations further?
First of all, thank you so much for inviting me. And I'm so happy not to talk about Global. You are right. So even if these are important topics for all the pharma industries. So I want to thank you, first of all, also, Ms. Agapitaki, because I found your speech really inspiring, but extremely promising. In the sense that there are words that you mentioned, sustainability of the healthcare system, learning from the past, integration amongst the different bodies on the healthcare, and you mentioned also how to be interconnected in order to react, to prevent or to react. I will go a little bit, and to cover your question, a little bit before of having this case, and why we need to keep investing, not increasing the cost of preventable measures like vaccination. So it is almost clear to all of us the benefit that vaccines can bring to the population. And it has been demonstrated with the childhood vaccination, so really successful, because it eradicates a lot of disease. Polio, for example, all around the world has been almost eradicated. But at the same time, we need to also consider what COVID, in terms of learnings, has brought to us, unfortunately, I would say. Or fortunately, depends how we want to progress. So if I consider these parameters, and considering the value of vaccination, which after the discovery of the clean waters is one of the most powerful public health intervention, we need to consider that we need to invest in this. And how we need to invest is really relevant. First of all, we need to understand that we need to shift with a paradigm, as you mentioned previously, about that the population is becoming older. And by 2025, 50% among one of them, will becoming over 50 in Europe. So if it is over 50, this means that this requires a different approach, an approach that goes towards an adult vaccinations. So a protection for the most vulnerable people who are also less relevant tools in their body to protect themselves. As we protect the children, the babies, because their immune system has been not developed enough, we need to protect also the older adults, or the adults in general. And this one needs to for two main reasons. First of all, because we need to decrease the power and the burden that are coming to the healthcare system. Because we are talking about people with several diseases, like diabetes, respiratory disease, that normally are the most vulnerable people that are going to, to burden the hospitals. So, and they require, additional treatment. And secondly, because also these people are those who are actively from a job perspective. We're talking about over 50. We are not people who are in pension. So to me, we need to be strategic on the way how we approach and we protect this population, because this is relevant to maintain healthy, not just the healthcare system, but also the economy in Greece. So as a second point that I want to mention is, which is really relevant, is the recognition what has been done so far in Greece. We need to recognize, if I look at of the vaccination calendar, the Greek vaccination calendar is one of the most complete vaccination calendar in Europe in terms of antigen. So if you look at the antigen, all the antigens are present. If you look at where these antigens are going, which kind of population is benefiting of these antigens, we are not in a competitive way versus other European countries. And this will generate what? Inequity in the countries, because those who can afford, we can pay out of pocket, they can cover themselves, they protect themselves. The rest, probably the ones who deserve the most, they cannot.
Please give us an example that the shortcoming in the Greek calendar.
So give an example, generic example. In other Portugal is similar to us in terms of population, in terms of crisis, because they face also an important crisis. But the level of investment and funding on the prevention and vaccination calendar, including is far higher than ours. So there is also an additional approach that cannot work in the forthcoming years. The approach that Greece has always taken was a stepwise approach. I included vaccines for the most vulnerable people rather than the population, and in the forthcoming years, I will introduce for the overall eligible population. So vaccines are the preventable tools that needs to be benefit the healthy population, not the at risk, just the at risk. So this generates inequity. You mentioned meningitis. I will give an example. You mentioned the meningitis about what is coming after a person, a baby, can be infected, unfortunately, for the meningitis. It's a rare disease, absolutely yes. But can you tell me why in Greece people need to pay, parents need to pay to have access to the vaccination, while in Portugal, in Italy, in Spain, in all the other countries, they receive for free? One of the justifications was low epidemiology. But my question is an open question. What if the parents that currently are paying out of pocket stop paying for protecting their own children? What is going to happen in terms of number of cases? So you create inequity in Greece, but you can create inequity also amongst European countries. And if you shift to the adult vaccination, so we need to properly found and invest properly in preventable measures, as you mentioned previously, with all the action that you mentioned, but also invest more in vaccination. Because also we invest as a country less than 0.5% of the overall investment of the healthcare system. So is very low. So that's why it's important to keep the investment and to keep the speed. Because speed means that when innovation comes, by the way, 100 vaccines are ready to be delivered in the market, and 46% are tackle diseases that are for all, adult population, which currently we don't have a current cure, like RSV, for example, and 80% of those are tackling the adults. You can understand where, the focus is. We should be ready when all the innovation is coming to the country, to maximize.
8 out of 10 of the new vaccines would be for not for children, but
for adults,
for people over 50.
For people over 50, 60.
This means we must change our mindset about vaccination.
When you mention paradigm shift, is exactly this point. So, and COVID has been a great learning for us, honestly.
So because how can we speed up the...
So first of all, it has been very clear that a stepwise approach doesn't work. So when you decide that there is a new vaccines already, by the way, recommended in all the European countries, we cannot stay behind. Because our citizens are not less important than the rest, considering the epidemiology, of course, that we have in Greece. Secondly, found properly, these vaccination, calendars. So increase the funding, and I'm really happy in hearing that you said previously there are 600 million that you are keeping investing in preventable measurement, which is, I hope, that this can be direct a little bit also on the vaccines. Third, we need to put targets, because if you don't, after including a measurement...
Give me an example, a target.
I will give an example on flu. Flu vaccines is a well-established vaccination. And there is a target, a vaccination coverage that needs to be reached. 75% is the minimum. If you go to the CDC website and you see Greece, you see 0. So the point is...
This is not 0, of course.
It is not. But one of the point was which kind of level of registry we put in place, how we measure this target, how we also invest in helping the population, monitoring, but also helping the population to be aware, as we did with COVID. So I believe that COVID has been a great example. I do recognize that because we need to also be, give the recognition for what has been done so far in a very good way. So having the dedicated budget for vaccines since 2019 is a great, because it's out of all the governmental measures that you mentioned previously. But at the same time, we need to keep the speed, invest more, and highlight the benefit more of vaccination. Last but not least, which is important, because you mentioned previously about the interconnection. So currently, we don't have interconnected body for vaccination, because you have a reimbursement committee, you have a negotiation committee, you have a scientific committee called the NITAG in English. So all of these are independent. It may happen that you get an agreement on price with the government, for example, with the negotiation committee, but there is not an endorsement by, for example, a scientific committee. These three elements, these three bodies, needs to be interconnected. So, and currently, these are not independent.
Yeah, I see. So let's go in Greek. Sure. Put your earphones. Okay. Κύριε Φραγκούλη, έγιναν αρκετά πράγματα την προηγούμενη κοιτάπητος στο θέμα του προσωπικού παύλα οικογενειακού γιατρού.
Mr. Fragoulis, a lot of things have happened. You are participating in this institution. You have recognized that there are weaknesses, deficits, and in order to be effective, we need to cover the rest of the population. What steps shall we take at this institution to be taking advantage of the population?
Let me start by saying, with two comments. We are very happy that at the political level, public health is under Mrs. Sarabidaki, and she has spoken about this interconnection. The primary care is actually the executive branch of public health within the community, and that's what we hear, that in the table that Mrs. Sarabidaki mentioned, they didn't have the so perfect vaccination program, but they did better in their execution of vaccinations, because we didn't have the GPs, which are a pivotal element in these networks. And we have the same problems in prevention. The strong primary care systems give very good results in the community. Also, as Mr. Birocchio said, we have to strengthen. If we finance primary care, this is not an expenditure, this is an investment. So we have to increase the coverage that we provide to the population. Indeed, we have taken a leap in the previous government in this part. The GPs did not start now. For the last 10 years, we've been trying to create this element, but now from 10% we've reached 55%. That's important. Now we have to go to do better even, to increase the coverage of the population. Yes, of course, we don't want to disappoint these 55%. Of course not. We have to incentivize so that more doctors enter these groups of GPs. I think that we are reaching the critical mass. Of GPs, or counter incentives as well we might provide. Also, we need to see how we can cover the population better. Number two, as we already mentioned, we need to organize at the local level primary care and in an organized manner, that so as to interconnect the GP with the other health professionals and the specialized doctors and the social services, because I cannot do something if I act alone. We need to have this network. So we could add the element of remuneration, compensation. We need to evaluate the results of the primary care, the services that we offer, and we need to record what goes on. We need to have indicators in order to monitor performance. Of course, we need a medical file. We do not know what we need to do. And of course, we can connect the two via pay for performance incentive. Okay, so you already have the data. Indeed, we do have indicators. We have data using the tools of the vaccination program. In some countries, they have, for example, a bonus of €5 if they reach a certain goal for each patient. Or via the RRF, we can have some funding so as to incentivize more doctors to enter the GP scheme. This is very important. I have worked with the World Health Organization in the past, and I can see what happens in other countries. In Portugal, for example, by connecting payment and performance, they managed to have better health and less medications, with a better diagnostics, better pap tests, better mammographies, etc., because people exercise prevention. So, from the doctors that we already have, how does it go? Some citizens have chosen accidentally any GP that the system would propose. Yes, indeed, and we have the cases where people have been enrolled under a specific GP, but they continue visiting another doctor that they had in the past. The European Union had suggested for incentives so that the citizens can be attracted to enroll to a GP. Of course, if we have a citizen of 20 years or 40 years old, has different needs than somebody who is 60 or 80 years old. My son is 23. I can't pressurize him to get enrolled to a GP. He won't go to visit any doctor. But people who are older, they need. Have they gotten enrolled already? Yes, at the largest percentage, we have enrollments at over 75%, but they do not use the service. So we have to explain to them how to use the service of a GP. Myself, I also saw a campaign to communicate the function to the end users. I think that we should see this campaign operate in time. Have you thought of these counter incentives that you had suggested in the beginning? Okay, let me answer to your questions. In Greece, we pick our doctor. We visit the doctor that we want to, we trust. But we need to have a steady contact point with the health system. And we need to understand that this can be compulsory and that we might have problems if we don't. Of course, in the deployment of the program, we want to see what we can improve. We have to change mentality. We don't have a tradition of prevention in Greece. We don't have a tradition of primary care. So we have to convince people to understand what these tools are, why they need them, and how they can facilitate their life by choosing in the most convenient way. So can all GPs be steady in the provision of their services? I think not. They don't have the same knowledge. They don't have the same time. This happens in all countries. So how can we support these people? How can we help them not to spend time in data entry? Let's give them a digitized system to work with. Already we are starting with this work. We need populations data because we have collected survey data from vaccination, for example. And I always speak about the vaccination paradigm because we can provide reliable information, reliable data now. In Greece, we have ignorance as regards vaccination. We believe that vaccines are for little children, not for the adults. If we go to visit the GP, they are going to inform us which are the vaccines that we have to take, how we can have them without paying a lot of money, etc. Moreover, one could think about how to improve the system in the dimension of integrating the committees, their operation, etc. However, we've seen the example of the vaccination committee. It was established based on scientific criteria, not based on financial criteria or the cost. We wanted a best practice here. That was the foundation for the policy making. So we need to know that if we incorporate new vaccines, we are based on scientific criteria. And if the committee says that if a new vaccine is beneficial for the population, then it is approved and we proceed. To conclude, let me say that, yes, of course, we'll cover the population. These are our objectives. That's the aim of the primary care units. For example, until 2030, 90% of girls have taken the HPV vaccine. 90% of women to participate in screening programs and early receive therapy if they have any traces. Also, we want to prevent uterus cancer connected to the HPV as well tools. So we have to change our approach. We have to specialize doctors. We have to communicate to people. So we'll have a more integrated service provision because now we have excellent examples at the primary care level, but also very bad ones because you know very well that we haven't given support to these people for years. And maybe some people are burnt out or are reluctant now. I do understand this for the GP and for the vaccination. I think that vaccination, the pandemic was a crash test for all these mentalities. Even those who don't visit a doctor ever understood that it is useful to have a doctor to ask for their opinion. But what about information? This is a political action to inform people. This is a policy. It's not a phenomenon in the society. Health literacy is one of the most important things in health. So we might organize a conference only about the tools that we deploy under the RRF. I think that you have to invest both in time and in monies in order to create campaigns to inform the public. Targeted population, targeted audiences. And let me say something very specific. We are going to have a heat wave in the next days, and the Ministry of Health issued a circular to the departments, to the divisions, to the personnel. In Greece, we have a problem as for who disseminates reliable health information. We don't want to be likable, we want to be useful. So we have to utilize all our means that will reach out to the public with reliable information. You know very well, when I was in the Secretariat, I think that the ecosystem of health for health literacy in people, we have Health Flicks as a useful tool because things have changed. Information is important, but it's not adequate so that people change their behavior. I do agree on that, and indeed, the Ministry of Health has to certify the information so the citizens can read something which is reliable. You know that there are many sources that disseminate disinformation, and the citizens are not doctors. They do not know whether X or Z site is more reliable than another website. Or we have conflicting messages. We don't know whom to trust. And in the end, you just pick up the most easy, the most simple solution. But sometimes this simple solution is scientifically unreliable and dangerous sometimes. So if we close the gaps in information and wishing to empower people, we change the journalistic landscape of health information as well, related to skills. We have to finish with this panel. I would like to thank you, everyone. I am very optimistic after what I heard, not so much about the changes in the hospitals, but the changes of the primary care. You haven't spoken with our ministry. That's you're not so optimistic. Yes, they should be here, all of them. Thank you very much for being here.
Ναι, ελάτε. Θα κάνουμε ένα διάλειμμα 10 λεπτών να αλλάξουμε τα μικρόφωνα.
5 minutes and then when we change the panel.
Κυρίες και κύριοι, μην σηκώνεστε αν είναι εύκολο. Θα παρακαλούσα τους συμμετέχοντες ομιλητές στο τελευταίο πάνελ να ανέβουν, δηλαδή τους κυρίους Γιώργο Δαφούλα.
Mr. Dafoulas is invited to the podium. Eleftherios Thireos, general practitioner. head of ODP and General Secretary of the Medical Society of Athens, and Mrs. Tsuma, CEO of IDIKA.
Ελάτε. Τις σημειώσεις μου. Ωραία. Στο φετινό συνέδριο είπα να βάλω την ψηφιακή υγεία στο τέλος για να κλείσω αισιόδοξα.
I wanted to introduce digital health in order to have an optimistic closing of this conference. I assume that a lot of things will become better in the next period. Mrs. Tsuma, what has been done and what are our priorities in health and IT? What we need to say is that we have designed a huge action concerning health in general in our country in cooperation with the Ministry of Health. Important actions have been also planned. Health file, patient's health file, patient's record is something that we are going to complete. We have data collected for the patients and the ministry, so we try to complete having data from all aspects of primary sources we have from prescription, data from prescriptions, from registers of vaccination, from recent reports by hotels. We have data from diagnostics, which means that gradually we will have the structure of individual patients' file. We need extra data from hospital because as patients we do visit hospitals. So we will interconnect all systems and hospitals. The structure of the patient's file is important, and we need to clarify who sees what. Interoperability with the hospitals. Doctors should have access to medical records and files, and doctors according to their specialty and what they examine in a patient to be able to see the initial data that is necessary, and then the rest of information. For example, a surgeon needs a different piece of information than a dentist. All these data, that it is a huge record for each and everyone, should be planned in order to have such a structure that can be processed. The second big action is digital modernization of the hospitals at a level of infrastructures and systems so as to be able to have a minimum set of e-services achieved. These are projects of RRF, which means that we should have completed them within the next 2 years. My Health App, which is the front line towards the citizen. Citizens see this application. How many have downloaded it? 420,000 Greeks have downloaded it. Too much or not? Compared to the population we have, it's okay. Not all of us have smartphones. This application is a complementary way citizen can find its individual medical record. My Health App includes all the so if I have let's see the stages first. This very moment, the Ministry of Health should have the data of the public medical record. The next stage is to be able to connect ourselves with private hospitals. But we talk about public health as a public good offered to citizens paying taxes and have the services offered by the state. We don't want to cover as a public the rest of things, the resources spent by the public sector is to offer public health care. We will receive data from the private health system, but we need other manipulations there. If I go to a private clinic for a test, blood test, if I give my AMCA to Vioiatriki, for example, wouldn't that information come to IDICA? All our exams of this kind, we all do that in Vioiatriki. Oh, we all go to the private clinics. So what is happening as a prescription, and we go to a private diagnostic center, is paid by the state. If we go alone and say, I want a blood test, this is our own initiative, because we want to have exam today. This is registered in the center, but it has no obligation to give it to us. It will give it to you, but in a public sector, doctor prescribes a test, so it is offered by the service, as a service by the state, and we cover as information what is offered by the state. So we have the individual medical record created in public structures initially, at its latest stage because we have steps. At its latest stage, and after finishing with public structures, we will ask the private ones to give their data in order to have a full medical record for everyone. So in My Health, we get some data from hospitals. Well, right now we have 120 hospitals, and gradually we get papers for hospitalization and various tests. Enriching the system with all the data will occur in combination with the hospital. We will go there. Most hospitals have IT. In the last 20 years, most of the data they have are digitized, but they remain in hospital. In the past, we might have records handwritten that are digitized. The issue of hospitals here is not what the data hospitals have, but interoperability is the key word. I go to a hospital.
Ο γιατρός στο άλλο νοσοκομείο που πάω, τι έκανα στο προηγούμενο, να ξέρει τι θεραπείες έχω πάρει, να ξέρει τι αλλεργίες έχω. Έτσι. Αυτό είναι το αποτέλεσμα και η χρήση του φακέλου. Αυτή τη στιγμή πάμε σε ένα νοσοκομείο και τους λέμε προσοχή, έχω αλλεργία σε αυτό. Και αν τυχόν πάμε με ένα ασθενοφόρο...
Εδώ τώρα, για να πάω και στον κύριο Θηραίο, γιατί εμπλέκεται και κλινικά αυτό που ρώτησα, θα μπορούσα να πάω εγώ να πάρω ένα φάρμακο χωρίς ιατρική συνταγή από ένα φαρμακείο, να πάθω αλλεργική αντίδραση από το φάρμακο αυτό, τον ατομικό ιατρικό φάκελο που είναι διαθέσιμο αυτή τη στιγμή δεν θα δείτε ότι πήρα αυτό το φάρμακο, δεν είναι. Εκτός και αν με ρωτήσετε αν έχω τις αισθήσεις μου και σας πω ότι πήρα αυτό το φάρμακο. Είναι ένα θέμα αυτό, έτσι σοβαρό. Τέλος πάντων, αλλά να μην επεκταθούμε σε αυτό.
Το κρατάω πάντως για τη συνέχεια.
Ναι. Έχουν γίνει αρκετά πράγματα, έργα έχουν δρομολογηθεί. Ποιες βλέπετε εσείς να είναι οι πιο άμεσες προκλήσεις που έχουμε να αντιμετωπίσουμε στην απόδοση αυτών των έργων, φυσικά?
Ναι, νομίζω, όπως το είπε και η κυρία Τσούμα, τα εμβληματικά έργα και η υλοποίησή τους είναι εξαιρετική αρμοδιότητα και λειτουργούν εξαιρετικά μέσα από την ΕΔΙΚ. Ο ρόλος του Υπουργείου Υγείας είναι να βάζει κάποιες προτεραιοποιήσεις και, αν θέλετε, να ανατροφοδοτεί αυτά τα έργα με την εμπειρία των ασθενών και με τις ανάγκες των ασθενών. Άρα, λοιπόν, οι όποιες προτεραιοποιήσεις από πλευράς Υπουργείου Υγείας θα πρέπει να στηρίζονται στις ανάγκες των ασθενών και πώς προσεγγίζουν την έννοια ψηφιακή υγεία οι ασθενείς μέσα από το σύστημα υγείας. Ποιες είναι οι προτεραιότητες τους, λοιπόν? Πρώτα-πρώτα να βρουν μια δίωδο στο σύστημα υγείας. Ήδη έχει αναπτυχθεί το σύστημα το e-ραντεβού, λειτουργεί εξαιρετικά στην πρωτοβάθμια, νομίζω θα επεκταθεί αργότερα και για τα νοσοκομεία και όλα αυτά. Άρα η είσοδος του ασθενών, η δυνατότητα να έχει πρόσβαση στις υπηρεσίες υγείας μέσα από ένα ολοκληρωμένο ηλεκτρονικό σύστημα ήδη υλοποιείται και θα επεκταθεί. Η δεύτερη προτεραιότητα των ασθενών είναι τα δεδομένα τους να τους ακολουθούν στο ταξίδι της φροντίδας τους. Στο ταξίδι στην αναζήτηση της φροντίδας να τους ακολουθούν τα δεδομένα. Βασικό εργαλείο είναι ο φάκελος υγείας. Και προφανώς με την εφαρμογή My Health App είναι αυτό που τον ακολουθεί. Το έχουμε. Αναφέρθηκε η κυρία Τσούμα για την επέκτασή του στο επίπεδο ηλεκτρονικού φακέλου. Άρα πρέπει να γίνουν μερικά πράγματα αυτά. Ακόμα. Το ένα είναι πέρα από αυτά που είπε η κυρία Τσούμα όσον αφορά τη δομή του, την επέκτασή του και την συμπλήρωσή του. Ένα βασικό που πρέπει να γίνει είναι να επεκταθεί σε όλους τους γιατρούς τουλάχιστον, αλλά και στους επαγγελματίες υγείας, στους γιατρούς. Δηλαδή, αυτή τη στιγμή την ευθύνη του φακέλου την έχει ο προσωπικός γιατρός. Αλλά ο ασθενής κυκλοφορεί μες στο σύστημα, έχει τη δυνατότητα να επιλέξει τον καρδιολόγο του, έχει τη δυνατότητα να επιλέξει τον ορθοπαιδικό του, άρα τη δυνατότητα και σε αυτούς τους γιατρούς να μπαίνουν και να καταγράφουν το ιστορικό, ακριβώς το παράδειγμα που είπε η κυρία Τσούμα. Όταν πάει σε ένα ορθοπαιδικό, θέλει πολύ συγκεκριμένα δεδομένα να καταγραφούν και να ενσωματωθούν. Άρα, ναι, έχουμε το εργαλείο, φάκελος. Ναι, χρειαζόμαστε επέκτασή του στους επαγγελματίες και στους άλλους γιατρούς, αλλά ακόμα θέλετε και στους επαγγελματίες υγείας. Τα εμβόλια, ας πούμε, οι επισκέπτες υγείας θα κάνουν στα κέντρα υγείας να μπορούν να τα συμπληρώσουν και να καλύψουν τις ανάγκες αυτούς. Ένα βέβαιο σημείο σημαντικό εδώ, αναφέρθηκε η κυρία Αγαπηδάκη προηγουμένως, στο προηγούμενο τραπέζι, είναι η πληρότητα και η ποιότητα των δεδομένων που μπαίνει εκεί μέσα από πλευράς γιατρών. Και εκεί νομίζω η ΔΙΚΑ έχει προχωρήσει πάρα πολύ στη λογική, αν θέλετε, της διαλειτουργικότητας, να μειωθεί ο χρόνος που ο γιατρός πρέπει να συμπληρώνει στοιχεία και να συμπληρώνεται αυτόματα από υφιστάμενες εφαρμογές, είτε λέγεται νοσοκομείο, είτε λέγεται φάκελο ή οτιδήποτε. Ένα τρίτο που αφορά πάλι το ταξίδι των ασθενών είναι το σύστημα των παραπομπών. Εφαρμογή υπάρχει, την έχει αναπτύξει η ΔΙΚΑ. Εμείς ως γιατροί, όσοι από εμάς την ξέρουμε και την υλοποιούμε, αλλά ο κύκλος δεν κλείνει.
Παραπομπές του ασθενή πού?
Παραπομπές από το πρώτο σημείο επαφής, εμένα ως γιατρός στο κέντρο υγείας, που θέλω να το στείλω σε ένα νοσοκομείο. Αυτή η εφαρμογή υπάρχει στην ΕΔΙΚ. Αλλά το πρόβλημα είναι ότι δεν κλείνει ο κύκλος. Δηλαδή, εγώ μπορώ να κάνω την παραπομπή, αλλά δεν μου απαντάει κανένας από πλευράς νοσοκομείου ή οτιδήποτε. Άρα, με αυτή την έννοια, αυτό το ταξίδι του ασθενή και η παραπομπή, που είναι πλούτος δεδομένων που ενσωματώνονται στο φάκελο, θα πρέπει να κλείσει και αυτό. Η τέταρτη προτεραιότητα είναι αυτά που θα τα συζητήσουμε προφανώς και στη συνέχεια.
Τα δεδομένα πώς αξιοποιούνται?
Ναι, αυτή τη στιγμή το σύστημα της παραπομπής έχει κωδικοποιηθεί από πλευράς ΔΙΚΑ. Το θέμα είναι να κλείσει ο κύκλος από εκεί που τον παραπέμπουμε, ώστε να απαντήσει και να μπουν τα δεδομένα αυτά μέσα. Θέλω να πω λοιπόν ότι οι δομές, οι υποδομές και αν θέλετε αυτό το ταξίδι του ασθενή με τις στάσεις τους, έχουν διαμορφωθεί οι στάσεις. Το θέμα είναι πώς θα μπουν τα δεδομένα, πώς θα γεμίσουν αυτά και τον φάκελο υγείας. Μια τρίτη προτεραιότητα που έχουν οι ασθενείς είναι, ειδικά που αναφερθήκε κατά κόρον και στο σημερινό συνεδριό σας, είναι τι γίνεται με τους ασθενείς. Αναφέρθηκε η κυρία Τσούμα βεβαίως ότι σταδιακά που μέχρι τώρα η ΔΙΚΑ έφτανε μέχρι την πόρτα του νοσοκομείου, τώρα μπαίνει και δεδομένα νοσηλευομένων και γεμίζει το φάκελο και έχουμε αυτά τα δεδομένα. Τι γίνεται με τους ασθενείς κατοίκων, την κατοίκον φροντίδα. Οι υπηρεσίες λοιπόν τηλεϊατρικής, τηλεσυμβουλευτικής, τηλεφροντίδας έχουν γίνει σημαντικές πρωτοβουλίες και από πλευράς πολιτείας. Το δίκτυο τηλεϊατρικής πλέον, σαν ένα έργο RRF, έχει επεκταθεί πέρα από τη δεύτερη υγειονομική περιφέρεια. Και άρα λοιπόν και συγχρόνως υλοποιούνται έργα όπως από τη δική μας την πλευρά, σαν ΟΔΠ, το Hospital at Home, την κατοίκον φροντίδα. Άρα θα πρέπει λοιπόν να αξιοποιήσουμε και αυτά τα δεδομένα να ενσωματωθούν στο φάκελο του ασθενή και υπάρχει πρόβλεψη και αυτά. Μια τέταρτη προτεραιότητα είναι αυτό που λέμε, αν θέλετε, και αναφέρθηκε πάλι και στο συνέδριό σας, να φτιάξουμε, και έχει σε μεγάλο βαθμό προχωρήσει αυτό, στη διαμόρφωση, αν θέλετε, του κουρίκουλουμ εκπαίδευσης των επαγγελματιών υγείας στο κομμάτι της ψηφιακής εγγραμματοσύνης. Να μάθουν να χρησιμοποιούν. Ήδη ξεκινάει ένα έργο RRF για την εκπαίδευση των επαγγελματιών υγείας στην πρωτοβάθμια. Ένα υποσύνολο της εκπαίδευσης αφορά ακριβώς την εξοικείωση και την εφαρμογή των ψηφιακών εργαλείων. Και τέλος, το τελευταίο, που είναι, αν θέλετε, η προτυποποίηση της φροντίδας των ασθενών σε επιλεγμένα νοσήματα, που σημαίνει τι? Σημαίνει από την πρώτη επαφή με την πρωτοβάθμια φροντίδα, την έγκαιρη ανίχνευση, την έγκαιρη διάγνωση, την παραπομπή, εξού και το σύστημα των παραπομπών, από τον γιατρό πρωτοβάθμιας και τον προσωπικό στο γιατρό ειδικότητας, ή αύριο μεθαύριο σε ένα κέντρο εμπειρογνωμοσύνης. Όλη αυτή η προτυποποίηση της φροντίδας στηρίζεται σε εργαλεία που ήδη έχουν αναπτυχθεί, μητρώα, θεραπευτικά πρωτόκολλα κλπ. Πρέπει να επεκταθούν, γιατί ουσιαστικά καταγράφουν έγκυρα και έγκαιρα την πορεία του ασθενή και μπορούν λοιπόν να αξιοποιηθούν για αυτή την προτεραιοποίηση της φροντίδας και την προτυποποίησή του. Κυρίως, αν θέλετε, και με τη λογική ότι ξέρουμε ότι τα δύο χαρακτηριστικά του Έλληνα ασθενή σήμερα είναι η αυτοπαραπομπή, μόνος του ψάχνει να βρει που θα πάει, και το δεύτερο είναι ένας ασθενής ταξιδιώτης. Ξεκινάει από την περιφέρεια και ψάχνει ένα κεντρικό νοσοκομείο και ένα πανεπιστημιακό να βρει μια λύση. Αυτές οι διαπεριφερειακές ροές, προφανώς με ένα ολοκληρωμένο σύστημα, θα μπορούσαν να περιοριστούν με την έννοια ότι κοντά στο σπίτι μου, κοντά στην οικογένεια, έχω τον προσωπικό γιατρό, έχω τις υπηρεσίες, έχω ένα γειτονικό σε μένα μονάδα δευτεροβάθμιας φροντίδας να μου καλύψει βασικές ανάγκες και ο προσανατολισμός του σε μια εξειδικευμένη φροντίδα να γίνει πολύ συστηματικά και πολύ προχωρημένο. Και τέλος...
Ακούσαμε την κυρία Καπηδάκη αυτό το σύμβουλο υγείας.
Ο σύμβουλος υγείας